Satu, dua, tiga, empat, lima.
Assalamualaikum warahmatullahi wabarakatuh. Good morning. Allow me to extend our warmest greetings to our eminent speakers and guests. President of World Federation of Neurosurgical Society, Professor Franco Servade, President of Asian Congress of Neurological Surgeon, Professor Yoko Kato, MD, PhD, President of Indonesian Neurosurgical Society, Professor Abdul Hafiz Bajamal, MD, PhD, the Vice Rector of Mataram University, Mr. Agustin, SA, MBA, DBA, President of Asian Congress of Neurological Surgeon Web Conference 2021, Rohadi, MD, PhD, doctors, and all participants. Thank you for joining the second Virtual Asian Congress of Neurological Surgeons 2021. It is a great pleasure for medical faculty of University of Mataram and Indonesian Neurosurgical Society to organize this event. I'm Sakina Sanat, who will be hosting this event. Before we start our main agenda for today, I would like to welcome the President of ACNS Web Conference for 2021, Rohadi, MD, PhD, neurosurgeon, to deliver a brief speech. To Dr. Rohadi, the floor is yours.
Thank you, MC. Assalamualaikum warahmatullahi wabarakatuh, and very good morning, the one and all present here. My name is Rohadi. I'm a neurosurgeon from Lombok, Indonesia, and I will be giving the opening speech for today's conference and kicking off the 3 days event. Before that, I received sad news from the society that Prof. Tetsuo Kano, founder of ACNS, had passed away yesterday. Personally, on behalf of all youth, express my deep condolence for us. He is an inspiring mentor and a teacher to all of neurosurgeons around the world, especially in Indonesia. In our heart, you shall remain forever. Dear Professor, Doctor, Speaker, invited guests, and all participants. The event has been started since yesterday and will continue until tomorrow. Despite the pandemic of COVID-19, in order to promote the Asian development of neurosurgery, publicize the concept of standardized and precisional treatment, and improve the overall level of diagnostic and treatment of neurosurgery. And we take a step to hold virtual international neurosurgical conference hosted from Lombok, West Nusa Tenggara, from 6 to 8 August 2021. In the middle of this year, when it is still sunny and warm, we certainly welcome you to participate in this great international event. This conference is jointly organized by World Federation of Neurosurgical Society, Asian Congress of Neurological Surgeons, Indonesian Neurosurgical Society, Fujita Health University, and University of Mataram. Together, we have one of the biggest events of neurosurgeon in Asia. The purpose of the conference is to set up an international academic exchange platform from basic research and clinical practice with cutting-edge technique so as to promote cooperative research, exploration, and development of neurosurgery and related disciplines. The organizing committee of this conference will invite more than 20 international neurosurgeons and the both highest level, including Franco Servade, Vladimir Benes, Yoko Kato, Azmi Ilyas, Bin Su, Charles Liu, James Liu, and many other experts attend the conference. The conference has total of 3 workshops and 23 forums incorporating various forms of the keynote speeches, case discussion, training course, and paper contest. Distinguished delegates, ladies and gentlemen, so I'm touched and grateful that so many of you are attending here today. It is my sincere hope and personal commitment that this conference will be one step of many we will make in order to achieve what we set out to do. There is a long road to improve neurosurgical field and the crisis situation. With your participation and joint effort, the virtual second ASEAN Neurosurgical Conference will become a high-quality, cutting-edge international academic event. I am sure you will have fruitful and rewarding exchange in next few days. I will you every success that you yearn for and look forward to the learning about the outcome. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rohadi. Now we move on to the opening remarks from Mataram University. Please be invited Mr. Agustin S.A., MBA, DBA, the Vice Rector of Mataram University.
Thank you, Master of Ceremony. Honorable invited speakers, respected guests, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Good morning. First of all, let us thank Allah, the God Almighty, for blessing and guiding us into the right path, for granting all means and opportunities to be here to attend this very meaningful occasion. On behalf of the University of Mataram, I am the Vice Rector for Academic Affairs, representing the Rector of the University. Would like to welcome you to the second Asian Congress of Neurosurgical Surgeons. For the first time, this event is conducting virtually in this year. It is differently from previous year as we embrace a new normal, practicing safe social and physical distance due to COVID-19 pandemic. It is a great honor for us to become a host of this conference, where international neurosurgical scholars present and deliver their clinical experiences for developing cutting-edge knowledge and innovation for improvement of our future society. University of Mataram was established in 1962. Currently, the university has 9 faculties, one of which is the Faculty of Medicine. The total number of study program is 63, studied from vocational study program to the doctoral study program. The number of students is more than 30,000, which come from 28 provinces in Indonesia and 4 overseas countries like South Korea, Palestine, Turkey, and Timor-Leste. The Faculty of Medicine has been accredited A by the Indonesian Accreditation Agency for Higher Education in Health, and it continues to grow to contribute to the wider community. The university continues to pursue various activities and provide support to all academics to produce research, publication, and innovations, especially in the health sector. Therefore, this conference is very relevant to be held. We hope that the conference will continue to serve and encourage our neurosurgeons, and not only to present and share their clinical experiences and scientific research findings, but also to build a global network while learning the latest advancements and development of research in neurological surgeon field, despite we are in the COVID-19 pandemic situations. I'm particularly delighted with the collaboration in conducting this conference between the World Federation of Neurosurgical Societies, Asian Conference of Neurological Surgeons, Indonesian Association of Neurological Surgeons, Indonesia Medical Doctor Associations, Fujita Health University, and proudly the University of Mataram, trusted to become the main organizer of this conference. I still have been impressed with the great work of all committees that we can pay off the trust that was given to Faculty of Medicine of the University of Mataram as a host of this conference. Congratulations and a sincere thanks to the organizing committee headed by my colleague, Rohadi Medical Doctor PhD, for his effort and hard work. To all participants and to all presenters and participants, I wish you all the best and have a wonderful moment joining this conference. Lastly, I hope all participants will find virtual event to be fruitful with wonderful moment of knowledge and experience sharing. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Mr. Agustin. Next, I would like to invite President of Indonesian Neurosurgical Society to deliver his speech. Please welcome Professor Abdul Hafiz Bajamal, MD, PhD.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, dear colleagues. Let me first convey my congratulations to Dr. Rahadi, the chairman of the Committee of Second International Congress of ACNS, who has successfully held this Congress. And to the president of World Federation of Neurosurgical Society, Professor Franco Servade, I express my appreciation and thank you for your encouragement. On this occasion, I would like also to thank Professor Yoko Kato, the president of ACNS, for the continued support of Indonesian neurosurgeons. They're all friends. Day by day symposium and Congress will continue. An effort to stay updated cannot be hampered by even by the pandemic. This is an extraordinary spirit of us. Advances in diagnostic and surgical technique will be conveyed in this meeting by experts, and it will be a moral responsibility to all of us to continue to develop and improve ourselves. Dear friends, to my colleagues neurosurgeon, keep on giving the best to your patient, but we must not forget about patient safety and ethics in dealing with patients and ethics in communicating with colleagues, because the true value of our neurosurgeon is dependent on these two values. On this occasion, allow me, on behalf of all Indonesian neurosurgeon specialists, to express my deepest condolence for the passing of our teacher, Professor Tetsuo Kano. We have seen his contribution in supporting the development of young neurosurgeons since the year of 1980s. Most of Indonesian neurosurgeons have experienced his lesson, and most of them have even been to Fujita University. The last time Perspepsi Indonesian neurosurgeon organized the Lifetime Achievement was in 2016 at the ACNS Congress in Surabaya. Professor Kano will always be in our hearts, with prayers for his family to be given fortitude and success. And now, my colleagues, finally, happy Congress, keep healthy and take care of yourself, and take care also your family and all the community around you. May God bless you all. Barakallahu fikum. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi. Thank you, Professor.
Thank you, Professor, for the speech. We now will have a speech from the President of Asian Congress of Neurological Surgeon, Professor Yoko Kato, MD, PhD.
Great pleasure to give some welcome speech for the Second Asian Congress of the Neurological Surgeons, the Virtual International Conference. First of all, I would like to congratulate Dr. Rohadi, who is the chairman of the committee, and also Chancellor of the University Mataram, Dr. Suni, and of course, the President of Indonesian in society, Abdul Habib Bajamal, who dedicated a lot to the Indonesian Neuroscience Society. This is the virtual conference focuses on many things, but especially the young neurosurgeon. They made, of course, fantastic program, but they made some effort to educate the young neurosurgeon, the hands-on. That is the most difficult, I think, part for organizing this program. The virtual and hands-on is easy to say, but just show the video is not 100% to learn what the young doctors. So besides the first day, especially hands-on, but the second day is it contains so many nice, fantastic talks. So I think 2 days make very fruitful results for your life as a neurosurgeon. Please enjoy the 2 days conference. Once again, thank you very much for Professor Rohadi or organizing committee. Thank you so much.
Thank you, Professor Kato. Moving on, I would like to invite the President of World Federation of Neurosurgical Society, Professor Franco Serfadei, to deliver an opening speech.
Dear colleagues, dear friends, I am extremely happy to welcome all of you to the second virtual ASEAN Congress of Neurosurgeons. I have to thank Professor Yoko Kato, President of the ASEAN Congress, Professor Rohadi, local organizer in Lombok of this virtual event, Professor Afid Bajamal, President of the Indonesian Neurosurgical Society. My name is Franco Serfadei. I am the current President of the World Federation of Neurosurgical Societies. In this difficult moment, virtual education, virtual congresses, meetings and courses are extremely important. The ASEAN Congress has done so much for keeping alive education in neurosurgery during this terrible pandemic. I really want to thank all of you for coming to this virtual meeting. I hope it will be one of my last video messages because I really missed to meet all of you in the beautiful Indonesia. I have been in Lombok visiting the Gili Island before, and I remember the Indonesian hospitality. I really wish to be able to meet all of you in person as soon as possible. all my best regards and wishes for a beautiful meeting.
Thank you, Professor, for the speech. With that, the second Virtual Asian Congress of Neurological Surgeons is now officially opened. Ladies and gentlemen, Lombok is famous for its rich culture, and we are proud to show a little bit of the beauty of Lombok. We are going to present our welcome gesture to you all, a traditional dance, Le Gumi Mira. Please enjoy. Now please enjoy a welcome video from our committee. Before we move on to our main agenda, I would like to introduce Head of Medical Ethics Honorary Council of Indonesian Medical Association, Dr. Bukovisa Prawiroharjo, neurologist, an alumni of Medical Faculty of Indonesia University, who is now served as a staff in Department of Neurology in Indonesia University, who will present about patient safety and ethics. Please welcome Dr. Bukovisa Prawiroharjo.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all of the distinguished speakers and also leaders of the ACNS and also the Neurosurgeon Society, World Neurosurgeon Society. And also thank you for the Dr. Rohadi and team that has been invited me as a speaker also in your proudly and also a very great opportunity for the Lombok and Indonesia to help this item, but still in the pandemic right now era, that it is also proudness for us as the Indonesian Medical Association also to provide this in a optimal way. And I would like to share a screen about the presentation. So. Sorry. As we know that in Indonesia, the institutionalization of the ethics discipline and medical law in Indonesia consists of the ethical boards that consists of the organization that I lead right now, the MKEKID or the Honorary Medical Ethics Council. That has the center, region, several subspecialty also in the ethical committee. And the ethical body is also in the Indonesian Hospital Ethics Honorary Council and the Ethics and Legal Committee and subcommittee of the Medical Committee Ethics in the hospitals. And the other things is for the disciplinary board is the MKDKI under the Indonesian Medical Council. And also from the law bodies consists of the legislative and also the executive and law enforcement process. We know that for the clinical ethics and specialty are fundamental in our healthcare. The words ethics and moral are often used interchangeably, but there's a distinction between the two. And the WHO defines the patient safety as the prevention of errors and adverse effects to the patients associated with the healthcare and to do no harm to the patients. That several areas should be provided. There is the polypharmacy, high-risk situation, and also the transition of care. In those diagram should be provided in our care. And we should know also the IPSD. I know that all of us has been familiar with this due to our work in the hospital, which is the goal. There is 6 goals. The first is to identify the patients correctly, improving the effective communication, also the safety of the high alert medication, and ensuring correct site, correct procedure, correct patient surgery, reducing the risk of healthcare associated infections, and also reducing the patient harm resulting from falls. The 4 principles we have known that in the biomedical ethics is the respect for autonomy, non-malversation, beneficence, and justice, and one aspect is honesty. Those is the type of actors seem appropriate, the individual, institution, and also the society should be work together for this. And there are types of adverse events that may occur during patient care. And for the respect for autonomy is that we respect the patient and their family as a person, that we respect their autonomous choice is a right and not a duty of the patients. And the non-malfeasance aspects is the first do no harm, from the Hippocratic Oath. And for the beneficence is how we maximize the benefit to the best of the patient interest. for the justice is we calculated also the other aspects such as the distributive justice to other patients, the individual, institution, society, and also the every patient has the right to fair, equitable, and the last is the honesty is the relationship between the physician and patient should be in a level of trust, in a good level of trust. And we may face the ethical dilemma where we whether the condition we could prioritize one or multiple bias principle and put the other aside in the dilemma. And all of the dilemma that we face in the hospital context, we should document all of them. All of them is in the ethical dilemma documentation due to the SNARS or the standard national standard of the hospital accreditation in HPK 3 and TKRS 12.2. So we as also in the neurosurgeon and also all of the division should report all of the ethical dilemmas that we face from our care in that kind of documentation, and it is the part of the accreditation of the hospital. And from the practice norm, we can refer to the Indonesia Code of Ethics. The latest is the 2012 version. This is the practical norm, consists of the 21 chapters, chapter boundaries and verses, and also others medical ethic honorary council decrees. Besides the law and regulation from the government, from the legislative also, including the President, Ministry of Health, and Indonesian Medical Council. That should be, we should pay attention for those regulations so that it will help us whether we face other the ethical dilemmas or certain conditions that, and then we can refer to the regulations as how we express our practice in the best way for the best of interest of the patient also. The obligations is from the Article 1. Every doctor is obliged to uphold, live, and practice the oath and or doctor's appointment. The Article 2 is a doctor must always make professional decisions independently and maintain professional behavior in the highest measure. And the Article 3 is carrying out medical work. A doctor must not be influenced by anything that results in freedom and independence of the professions, such as political pressure, hospital business, proximity, senior pressure that is beyond professionalism, MLM or other interest motivations, and so on. And the Article 4 said that a doctor is obliged to refrain from acts that are self-praising. And the Article 5 is every act of or doctor's advice that may weaken psychologically or physical endurance must obtain the consent of the patient or family and only be given for the benefit and the best interest of the patients. And the Article 6 is every doctor must always be careful in announcing or implementing any new technique or treatment discovery that has not been tested for truth or not yet been tested for truth, not accomplished yet, and on things that can cause public unrest. The Article 7 said that a doctor is obligated to only provide certificates and opinions that have been self-checked. Article 8, a doctor is obliged in every medical practice to provide competent services with complete technical and moral freedom, accompanied by compassion and respect for human dignity. The Article 9 said that a doctor is obliged to be honest in dealing with patients and their colleagues, and endeavors to remind his colleagues when dealing with patients that he knows that he has deficiencies in character or competence or who commits fraud or embezzlement. The Article 10 said that a doctor is obliged to respect the rights of patients, colleagues, and other health workers, and is obliged to maintain the patient's trust. And as the example, maybe we can meet the ethical dilemma in emergency settings. Maybe it is not a problem in the developed country, but in Indonesia, also the other developing countries could face this kind of ethical dilemma. Whether maybe there is not a clear statement, not a clear status of the payment or insurance or the other fundings. Whether we can meet like a motorcycle accident, head trauma patients, arrived at the hospital and his vital signs get worsened. We could not contact the family yet, and for his best interest, we need as soon as possible do the invasive treatment such as intubation and decompression craniotomy. Whether the patient do not have the information or the status of the payment clarity, and yeah, we don't know the family order at that time. So that maybe at the present we have the ethical dilemma, but we should promote the best interest of the patient so that we then consider the non-malfeasance, how we prevent the patient's mortality and severe disabilities as the first priority at the moment. And the second is, the problem is we may treat status epilepticus patient maybe at the emergency ward, and suddenly the family asks to bring the patient to alternative medication because they believe the hoax, because in Indonesia there are several hoax like this, whether the families believe, and in such condition they want to bring the patient to the alternative medication because they believe that that will succeed. We know for sure if the medication right now is stopped, the patient soon will die. So that there is a dilemma between we are following the family order that may make the patients die, and then I think from this kind of perspective, we can also prioritize the non-malfeasance patient, non-malfeasance section of the ethical principle, that we can reject the family order because of it will make the patients die. And also there is an article here in the journal that the doctor specialist that is maybe in duty in the night shift has doing the ethical violations if only answering the by phone for the emergency help. The things is whether we can delegate much of our competencies only for the night shift for the emergency physicians. It is okay to observe them, maybe remotely from the phone. But if the surgery or other medical interventions that we cannot delegate to the emergency physicians, therefore we should come and then do the help to the patients. Maybe the further conclusion, ethics and safety is interrelated concept. They are moral ideals of the loss prevention are the basic concept for creating a safe culture. And the safety culture requires cultural change and unethical commitment to quality and implementation of the practice guidelines that support safe patient care. And also considering the Indonesian Medical Code of Ethics. Thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Good morning.
Thank you, Dr. Pukovisa. Next, let me introduce our first moderator for today, Professor Azmi Alyas. He did his Bachelor of Medicine, Bachelor of Surgery at University of Malaya in 1989, and then did his Master of Surgery in 1997. He was awarded Fellowship in Royal College of Surgeons, Ireland, and also Fellowship Academy of Medicine of Malaysia. Currently, he is the head of department and senior consultant neurosurgeon department of neurosurgery at Tunku Abdul Rahman Neuroscience Institute. Now I will hand this over to Professor Azmi to lead the first plenary lecture. Please welcome Professor Azmi Alyas.
Thank you very much. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Very good morning, good afternoon, and good evening to all colleagues from all over the world, especially in Indonesia. Selamat pagi. First of all, I would like to thank and congratulate Professor Rohadi for the successful organization. So we have a very good workshop yesterday. And now today, it's my great honor and pleasure to welcome you to the first plenary session of the second Asian Congress of Neurological Surgeons International Virtual Conference. So in this plenary session, we will have 4 speakers. Originally, we have 5 speakers, but unfortunately, Professor Francisco Savade will not be able to join us. So we will have Professor Yoko Kato from Japan, Professor Sridhara from India, Professor James Liu will present 2 topics today, and followed by Professor Binzu. So it is my honor to introduce the first speaker, Professor Yoko Kato. I think she do not need any introduction. She's a mother of all young neurosurgeons, and she is founder of many international meeting and congress and society, and she's currently the president of Asian Congress of Neurological Surgeons and professor at the Department of Neurosurgery, Fujita Health University. So it is my honor to invite her. She will talk about minimally invasive surgery for cerebral aneurysm surgery. So Professor Yoko Kato. You may start your presentation.
Today, my topic is minimally invasive strategies for cerebral aneurysm surgery. Before I start my lecture, I want to introduce about Asian Congress. So the Professor Kato is the founder of the ACNS. He is the founder, president. He is the emeritus professor of the Fujita Health University. So his philosophy is very strong to support wellness, always. So understanding of the patient and the neurosurgeon as human beings in spite of all the complexities of our world. So Dr. Sano is another my mentor. He's also the emeritus professor of the Fujita Health University, very skillful neurosurgeon. In the future, a giant elephant might appear, but there won't be any more mammals. Dr. Sano is the mammoth of the microneurosurgery. He loves microsurgery. He almost 24 hours. So this picture is taken at the beginning, the real beginning of the Asian Congress. At the beginning, we do not use the ACNS. Neurosurgery update for young neurosurgeon in Asia, so-called NUINA. So it was 1993. Professor Kando, he invited 100 YNS from the Asian countries. For 1 week, we stayed some dormitory to study and exchange their knowledge and also the social life and culture. So this is the table. So the next one will be organized by Professor Mao In. This is the 14th ACNS in next year in Shanghai. So we are all families now. So the current status, face-to-face education activity, it is quite difficult because of the COVID-19. So the travel restriction. But in the future, I think vaccinated people, the increasing, then we can make once again the in-person meetings in the world. So during this COVID-19 pandemic, the duration. So we can make non-technical skill online information, such as the neuroanatomy, neuroradiology, operative approaches, neurosurgical atlas, the Rosen collection, the respective journals of the neurosurgical organization. So on the other hand, the technical skill providing, such as virtual reality, such as operating the room, and also the simulation of the hands-on workshop. So as for the virtual reality, so in cranial surgery, in spinal surgery, especially the minimally invasive procedures, and also neurovascular surgery. So maybe we can show the video to the buyers and they can learn how to do step by step. As for the hands-on workshop online, so we can show them the bypass, embolectomy, intracranial stenting, image guidance, and robotics and spinal surgery. So today just I want to share coil versus kind of clip. So the cerebral aneurysm, the result of the ISAT, which supported the use of the novel endovascular procedures for the treatment of the ruptured aneurysm. So coiling for the ruptured aneurysm, they decrease the relative risk of dependence, death, when compared with the aneurysm clipping by 7.4% at 1 year follow-up. The national inpatient sample found that between 1998 and 2007 in the US, so significant increase in the number of the treatment of ruptured aneurysm. The further technological advancement in radiological imaging and endovascular interventions. So endovascular coiling is a minimally invasive treatment without the craniotomy. The coiling versus clipping for unruptured aneurysm. The surgical clipping resulted in lowered retreatment rates and was associated with a higher incidence of the complete occlusion. No significant difference in procedure retreatment rate. So significantly shorter the stay hospital in unruptured aneurysm patients treated by endovascular coiling than in those treated with the surgical clip. Endovascular treatment is a lower rate of the complication comparing with clipping, especially ischemia. So this is the forest plot for post-op ischemia, the coiling versus clipping. So the ischemia is much lower in the endovascular procedure. The trend of the treatment modalities in Korea, the higher cost for clipping, there was a significant increase in endovascular coiling between 2010 to 2017. So this is aneurysm clipping versus coiling. So it almost comes together, the clipping coiling in 2012 in Korea. The right side, the new devices of the endovascular treatment. So wide base and also the large type of the aneurysm, the endovascular strategy can be treated when we selected case. So the development of the new endovascular devices for aneurysm treatment. So the coiling is increasing in 2016 comparing with the clipping. And also the device assisted the coiling is also increasing in 2016. The trend of the ruptured and unruptured aneurysm, the treatment in the United States in post-ISAT era, national inpatient sample analysis. So these results tell us a total of the 50% patients who are treated for a ruptured aneurysm, 65.3% by endovascular and 34.7% by surgically. And also the almost 50% patient underwent procedure for subsequent hemorrhage, and the 56.6% by endovascular and 43.5% by surgically. So the endovascular treatment is more than the open surgery. The trend of the ruptured aneurysm treatment in the US, so definite the coiling is increasing already the year of the 2014. But in ruptured aneurysm, the treatment in the US, again the same tendency. In 2014, already the coiling is much big number of the open surgery. So from here, I want to show this the flow of diverter. So indication of the flow diverter. So the large giant wide neck aneurysm and the fusiform type and the recurrent aneurysm after coiling. And also the blister-like aneurysm, the failed the simple coiling. The development and the indications. The 2011, the first flow diverter approved for USA use in the United States, and coilable of the failed aneurysm trial. The wide neck, large or giant aneurysm of the intracranial aneurysm from the Petrous segment to superior hypophyseal artery ophthalmic segment. But criteria are extended. The small or medium wide neck, sacral or fusiform aneurysm from the Petrous to the ICA terminal. So mechanism of the flow diverter stent, how they can heal of the giant or very difficult aneurysm. The central diversion, so decrease direct jet blood flow into the aneurysm and promotes laminar flow along the stent in the direction of the parent artery. Decrease wall stress and stagnant flow result in aneurysm remodeling that ultimately promotes endothelialization. So the epithelium is very important across the aneurysm neck and the arterial reconstruction. So type of the flow diverter stent. There's so many types, but recently the flow redirection endoluminal device, FRED, is most popular now. So this is the small technique from the Korean neurosurgery. The complication of the flow diverter, the international retrospective study of the pipeline embolization device registry, the spontaneous aneurysm rupture in 0.7% were treated with pipeline alone, but the 0% when treated with a combination of the pipeline and the coil embolization. The coil embolization and the microsurgical clipping are viable treatment options for aneurysmal subacute hemorrhage patients. The therapeutic choice for poor grade aneurysmal subacute hemorrhage should be tailored to individual patients. The trend of the endovascular treatment is popular in the current era for both ruptured and unruptured aneurysm. So, I want to discuss a bit more. So this is I'm talking about unruptured aneurysm. So the shape and the rupture ratio. So if the aneurysm has a daughter sac, so more frequent rupture in the future. And also the size of the aneurysm. The larger one is a high frequent rupture in the future. So this is a risk factor of the enlargement and the future rupture and ruptured aneurysm. The 5-year risk of the rupture is a 3.4%, and the risk factor for rupture is more than 70 years old, hypertension, history of subsequent hemorrhage, and the aneurysm size is more than 7 millimeter. The location is ICPC and ACOM aneurysm. And also the geographical region, the Finland and Japan, is high frequent comparing with other countries. So on ruptured aneurysm, especially the smaller ruptured aneurysm, diameter 3 to 6 millimeter. So if the aneurysm size is more than 7 to 9 millimeter, is the rupture time is 3.5 times, and 10 to 24 millimeter 9 times, and more than 25 millimeter, so-called giant aneurysm, would be the 76 times the future rupture ratio. And also the standard protocol for aneurysm clipping at our university. So that we do the ICG video angiography before and after, and also we check the endoscope assist for check, especially blind corner of the aneurysm. And also we put additional the Dopplers and also the intraoperative monitoring, such as MEP. So this is how we can do the put the clip for a ruptured aneurysm. The beginning ICG and also MEP and also the CFD and also the ICG and endoscope. So this is a very small, tiny ACOM aneurysm. The CFD tells us a bit the thin wall of the aneurysm. So this is ICG, and this is endoscopic observation. This part is very thin, which indicated by CFD. Then we put the clip. So this is a very interesting image. This is a wall pressure of the paracardiac aneurysm. So CFD wall is very important. This is a before stenting. So this is the flow. And this is after placing the stent. So the inflow lamina is become very calm and very slow and very small. And this is after the putting the flow diverter, how the inflow has been changed. So this is we can predict before surgery. So it's very, very interesting how we can put the coil, how we can put the stent. So not only for the direct surgeon, but also the endovascular surgeon. It's a very useful information. And also this is a 4D image. You can see, so this part is a rupture part. This is corresponding here. So this is a very big change of the volume. This is ACOM aneurysm. So this body image is another very important information how we can treat the aneurysm. So this is the right diurnal approach. So another very interesting is aneurysm wall pathology, such as atherosclerotic change or dissection and vasculitis. When we treat of the large or giant aneurysm, one of them is just ballooning of the vessel wall, but the other one is a very thick wall with partially strong walls inside of the aneurysm. So we need some the hint how to treat of such kind of the thick wall, the giant type of the aneurysm. So there are several options. So the very thick wall of the aneurysm, so-called such as vasovasorum play role for the aneurysm growth. Proliferative, the disease of the vessel wall, we can say. So wall pathology of a large or giant aneurysm, one is a big role is the vasovasorum pathway. So this is one of the case, partially strong walls, the giant aneurysm, which is come from the left vertebral artery. So this is a preoperative image. That is a severe compressive of the brain stem. And the patient went to several clinics so that he received the treatment of the aneurysmal stent coil and then repeated stent or coil again. So this is the final situation of the aneurysm. So aneurysm wall is well defined, maybe due to the filling up by vasovasorum. So even several treatment has been done, but the aneurysm continues the enlargement and developed a symptom of the left facial weakness and the cerebral ataxia that came to visit our hospital. So finally, we excise of the aneurysm after the trapping of the aneurysm. So we recognize a so big vasovasorum on the aneurysm wall. So this is a surgical video. Just I want to share how after the skull-based approach for the posterior fossa, now we can see the aneurysm very huge, the big, the vasovasorum on the aneurysm wall we can recognize. Can you see here? So many the cranial nerves, almost 2 centimeters of the aneurysm in size. So those type of the aneurysm is most of them is partially thrombosed. So the vasovasorum is the big role of the growing of the aneurysm. So we cut the aneurysm and evacuate the surgical coiled part. And the clots inside of the aneurysm. And finally, we encounter of the stents, the main trunk of the vertebral artery. So this is a very ugly type of the very sick aneurysm. So this is histopathology is some such kind of the vasovasorum. So many you can recognize. So this is the outer layer. You can see the inflammation or vasculopathy recognized with the vasovasorums. So this is some mechanism which is reported by Aoki, etc. So inflammation. And this is the migration of the macrophage theory. This is also reported by Professor Aoki. in 2019. So this is some strategy how we can treat the aneurysm, because step by step. So we should consider about the preemptive the medicine. Maybe in future, I think the aneurysm treatment by drug. This is very ideal treatment. So recently we start the CFD superimpose of the aneurysm cartoon. So this is the image of the aneurysm before surgery. So it's a good practice for young neurosurgeon. The image of the intraoperative aneurysm and the location. So this is the 4 parameter of the CFD: pressure, the streamline of the vector. So we can superimpose the surgical cartoon. This is a very popular ICPC aneurysm. And this is the temporal, this is the frontal lobe. This is the left side, this is the third nerve, and this is the second nerve. So we can make such a basic cartoon and put the color. Then we can put the CFD, the aneurysm, on the surgical cartoon. So this is a real surgical procedure, and this is the preoperative, the image of the aneurysm. So that part is corresponding this part, the scene of the aneurysm wall. So this is the synchronized CFD, the parameter of the aneurysm. This is the pressure, and this is the red part is a very high pressure, and this is a wall shear stress, and this is a wall shear stress vector, and this is a streamline. So after I talked about a lot how importance and how development of the endovascular treatment for the several aneurysms, but still we need some open surgery for some case. So this patient onset was cerebral infarction. The patient developed paresis. So the immediate MRA or angio shows the no aneurysm at the trifurcation. But after some times, check once again, the aneurysm developed, aneurysm revealed. So this is a trifurcation aneurysm which had thrombus inside. So for this case, we decided to cut the thrombus part. Then for that purpose, we put the local bypass to the M3 branch. So after bypass, after bypass operation, we can see very nicely the anastomosis here. This is a STA, this is M3, this is a cartoon showing. So we excise this part of the branch. So here you can see that this part is already, some part is very dark part. It's rather fresh clots. So now we excise of the aneurysm, and the clip, several clips. And we divided the aneurysm. Then we occlude the aneurysm completely. But sometimes some part is still very hard. So the clip is slipping out. So this is the main trunk and this is the branch. So now we can see this is the part resected the aneurysm. All the inside is clot replacements. This is a post-operative 3D CT. So the one bypass branch come from STA to the inferior branch of the M3 and the 5 clips which occlude the aneurysm neck. Then we excise some part of the aneurysm. So one more case I want to share. So this is at the beginning we made a plan and two clip surgery. So one is ICPC. So the other one is vascular cheek aneurysm. So size of the angiogram process, then we can get a wider view. After the complete section of the cerebral fissure, and already here we can see the aneurysm. This is the third nerve. So aneurysm is very dense attached to the third nerve, and this is posterior climbing. This is the picon, and once we cut the arachnoid membrane, we can reach the posterior bosom. This is the vascular trunk. So this is a measuring of the ICPC. So this is the IC, and here is the ICPC aneurysm, which is very strong adhesion to the third nerve. After ICG, we can observe with endoscope. This is a posterior clinoid, and this is a picon. Some perforators from the picon, and this is anterocoidal. So this is the aneurysm. This is the third nerve. Can you see that this is the aneurysm tip is touching of the third nerve. So in beneath, we can now recognize the posterior circulation, the vessels. This is a vascular trunk, and this is a PC, SC, here is the aneurysm, this is a picon. So, but we gave up to place the clip because of the so many operators is attaching to the aneurysm dome, so we cannot place the clip without damage of the operators. So in this case, this is the picon, anterocoidal. This is a clipped aneurysm here, no more flow inside. So the endoscopic view, we can see very illuminated and also the high magnification and very nice resolution comparing with the microscope. So we abandoned to place the clip. So this is just reinforcement with the neon veil. So anyway, once we take open surgery, then we can see, we could understand many things. So this is a third nerve. So of course, the aneurysm treatment, the paradigm shift has been occurred. So most of the aneurysm is now treated by the endovascular. But still, some failed coil or failed endovascular treatment come back to the open surgeon. So another one is very sequel and giant and partially thrombosed, different type of the large type of aneurysm. Still should be treated by the open surgery. So much has been done, but there is still much to be done in aneurysm treatment. once we can see the better view, so when we can reach the higher place. So thank you for your attention.
Thank you very much, Professor Yoko Kato, for such a beautiful, comprehensive lecture. I believe that not only me, myself, the senior neurosurgeon and young neurosurgeon learned very much after watching your lecture. So she described the various techniques and her strategy, right, from preoperative, intraoperative planning and strategy using multi-modalities, fluorescent technology, and we give us a lot of information and better understanding in treating aneurysm. So she also described to us a various strategy in managing from small aneurysm to large aneurysm using endoscope and salvage procedure for failed coiling and so on. So thank you very much, Professor Yoko Kato, for your excellent lecture. But unfortunately, in this plenary session, we don't have a Q&A. So I shall move to the next presentation. It is my great pleasure to introduce the next speaker, Professor Chris Sridhara. I hope you are there. Okay, so Professor Sridhara is very familiar to everyone in Asia, especially. So he was the first president of the first ACNS International Virtual Congress, which was successfully conducted last year on 11 to 13 December 2020. So he has set a very high standard of international virtual meeting under the flagship of the ACNS. So it's going to be very hard for the subsequent organizer. Congratulations, Professor Sridhara. I enjoyed the session very much. So graduated from the Madras Medical College in 1982, and he completed his postgraduate training in neurosurgery in 1990s. And he worked at the National Neuroscience Center, Kolkata from 2006 to 2009. And currently, he is the director of the Neuroscience and Spinal Disorder from Gleneagles Global Health City, Chennai. So he also the assistant associate editor textbook of neurosurgery, which everyone very familiar, published by Professor Ramamurthy and Tandon, and also editors in many international journals and also executive committee in many international society. So it is my great honor and pleasure to invite Professor Sridhara. He's going to talk about microvascular decompression, surgical nuisance, and lesson learned. So Sridhara, to you.
Thank you very much, my good friend Azmi. And thank you, Professor Rohadi, for this kind invitation. Of course, Professor Kato and all the organizers. And let me congratulate you on this wonderful meeting. You have taken it up one notch higher from the meeting we had last year. I'll just share my screen. So before we start, I would like to pay my respects to Professor Tetsuo Kano. This was the photograph in 1993. Professor Kato referred to this, but I was one of the recipients, and that was me here in 1993. Many of the current stalwarts of Asian neurosurgery were the benefactors of benefited from this meeting, which was the starting point of the ACNS. And really, I think we all owe a lot to Professor Kano for this great initiative, for the great education which has been started in Asia and nobody's been able to replicate this sort of an initiative anywhere else in the world. So I think all our respects to him, and may his soul rest in peace. This is one of the last photographs I had with Professor Kano. Always very friendly, easy to approach, easy to talk to, and he was a wonderful gentleman. and we all will remember him always. Professor Kato has taken on the mantle of the ACNS and really taken it to the next heights. This was in Jakarta when we came for Ica's meeting for the ACNN, and this was I mean, what a journey that has been. And also, so let me congratulate Professor Kato for, despite the pandemic, keeping education going. And the ACNS has really been a leader in that, with all the webinars, with the young neurosurgeons activities. So congratulations, Professor Kato, for being who you are, ever active, ever green. So thank you so much. Going on, last year, Azmi, we spoke about this meeting, and it was a tremendous 3 days, and we had the ACNN alongside. So there were 3 halls where we had all these meetings, and almost everybody from everywhere in the world was part of this. And I hope that we shall continue to have such meetings, because there is no restriction of travel. There is no problem of getting a visa or expenses. I remember once we had a meeting of the ACNN, and the nursing had this concern about their expenses for traveling to different parts of the world for the meetings. But when we have these virtual meetings, it is so nice that we are able to meet people from all over the world, almost from our own homes. And this is a wonderful initiative, and I'm so happy that I could be part of this. And we had a wonderful meeting last year, and we are having a wonderful meeting right now as well. So thank you, Professor Kato, and the rest of the ACNS board for this opportunity. Coming to microvascular decompression, we cannot speak about microvascular decompression without mentioning Dandy. And in this paper in 1934, he mentions that not infrequently the artery leaves its mark on the nerve. At times, the nerve is attached to the artery, and in 66, that is 30.7%, the artery in some point affected the nerve. And this was in 1930s. But after that, it was only Peter Geneta, who's here, who took microvascular decompression and the neurovascular conflict concept to the next level, and really took it to the world and took the spotlight to that cause of the different causes of cranial nerve dysfunction in the posterior fossa. This is in 2005 in St. Petersburg. And these are some beautiful articles written by Peter Geneta, and there are many more written by him and his team at Pittsburgh, which highlight the cause of trigeminal neuralgia and other neuralgic syndromes of the posterior fossa. Now, we all know the anatomy. So there are 3 neurovascular bundles in the posterior fossa, each with their own neurovascular conflict syndromes. And these have all been described in literature, the commonest being trigeminal neuralgia. This is again from Peter Geneta's article, but this statement is something which I think is a wonderful statement. The problem is not whether there is a blood vessel present, but whether the surgeon is astute enough to find all the significant blood vessels. So when there are people who say, oh, the MRI does not show a vessel, there are sometimes we find that even though the MRI does not show a vessel, we can find a vessel if we are astute enough and if we look properly, so that we can find the cause of the trigeminal neuralgia at surgery. Of course, currently there are multiple options for trigeminal neuralgia and other cranial neuropathies. The first being medication, and all patients should have a trial of medication before you advise any intervention. Non-ablative procedures is only one, which is microvascular decompression surgery. There are many ablative procedures, which include glycerol injection, balloon compression, RF lesioning, radiosurgery. But I think the most important aspect of treatment in my mind is that when we treat some disease or a non-cancerous, which is something which has normal anatomy, we should try to preserve things and not be destructive. So the real advantage of microvascular decompression surgery is that it is non-destructive. It's an anatomical and physiological surgery with full function preservation. And I think that is what is very important. And this is a surgery which is a very beautiful, precise surgery, which only requires a proper arachnoidal dissection. This is the classical picture of trigeminal neuralgia and the causative etiology of trigeminal neuralgia, and the diagram representing where the compression will be most of the time, and where the pain would be with relative to the compression. If you look at the techniques of microvascular decompression, if this were the nerve and this is the artery, there are two basic techniques. One, the interposition technique, where you just place material between the artery and the nerve. And the other is the transposition technique, where you make sure that the vessel is moved away completely from the nerve. And the technique of placing the material is completely different in the transposition technique as compared to the interposition technique. And I think this is very, very important. And in my mind, doing the transposition technique is a much, much better, gives you much, much better results. The chance of recurrence is much lower than the interposition technique. Of course, there are times and the vessels involved do not allow you to do a transposition technique, in which case you have no option but to do the interposition technique. And we shall be looking at all these issues. A CT-MR is mandatory to rule out lesions which cause tumors and cysts. This is very, very important. One should not venture an intervention without doing a proper MRI. We used to do a CT initially, but now with good MRIs, I think that is very, very essential. It is also important to do MRAs, and also when you are looking at radiology, it's very important to do sequences like the TOF and the cyst sequences, which will show you actually how the vessel is. More importantly, you must look for doliectatic vessels, which will or can give you a problem at surgery. And for you to be prepared, this study of radiology before you operate is very, very important. One must also remember that demyelination is a common cause of trigeminal neuralgia. And this demyelination plaque is often seen at the dress zone of the trigeminal nerve. The distinguishing factor of between demyelination as a cause and a neurovascular conflict as a cause is that in demyelination, very often the symptoms can completely disappear without any medication for a long period of time, while in a neurovascular conflict caused trigeminal neuralgia, it does not disappear so often. Intraoperative monitoring is good to use, but for trigeminal neuralgia, I am not very sure that we need to use this, but definitely for other neuralgias and other neurovascular conflict syndromes, I do use intraoperative monitoring, and this is very, very good if you have it. I do the surgery in a supine position with the head turned like this. I prefer not to use a lumbar drain. I like the subarachnoid space wet. I think the subarachnoid cisterns should have CSF, and because a dry cistern is never very nice, and therefore I do not use a lumbar drain. We used to use this safety burr hole for a long time as a fallback on how we used to do posterior fossa tumors and other procedures. But now we have stopped using the safety burr hole. This is the incision that I use, a small incision behind the ear, and a coin-sized craniotomy or craniectomy based on the vessel, on the nerve that needs to be decompressed. Now, this diagram represents the posterior fossa, and what you need to expose is not the entire posterior fossa cistern, nor do you need to expose the entire cerebellum. A small craniotomy is more than enough, but that has to be tailored to whichever nerve has to be looked at. For example, the trigeminal nerve, you need to have the transverse and lateral sinuses exposed so that you can look at the entire trigeminal nerve from medial, the DRES and the brainstem, right up to the time where it exits the posterior fossa. For the lower cranial nerves, for glossopharyngeal neuralgia, it is good to have not only the lower cranial nerves exposed, but also a little bit of the vertebral artery as it enters the posterior fossa, because then that will give you access to the pica and the vertebral artery as they enter the posterior fossa. For the for hemifacial spasms and the cochlear vestibular nerve complex, you need to have a little bit of the lower cranial nerves also exposed, because your direction of retraction of the cerebellar surface should be such that it is not directly in line with the 7th and 8th nerves, but a little more from inferior, so that you can do not place traction on the 7th, 8th nerve complex. Small technical points: a very small craniotomy tailored to the nerve, as I said. You must open the arachnoid to release CSF and relax the brain. That is very, very important. Do not try to be in a hurry or a rush to get to the nerve. Open only the arachnoid sleeve of the concerned nerve. And I think if you have read the chapter on the subarachnoid cisterns by Professor Yasargil in his microneurosurgery books, you will understand what I'm saying, that each of these neurovascular bundles has their own cistern, and you can see that at surgery. And it is best not to open the other cisterns, because the CSF and the arachnoid sleeves serve as protection in case there is some movement of your suction or instrument that touches the other nerve. And very, very important is fine and delicate microdissection. And that is the key to good microvascular decompression. This is the size of the craniotomy that we do. It is about 1 inch, 2.5 centimeters, with the sinus well exposed so that you can really get a good exposure right up to where you want to go. And for a trigeminal neuralgia, please remember that you should be seeing this as soon as you open the dura. The junction between the posterior petrous surface and the tentorium, that is very, very important. If you are not seeing this, that means you are not in the right space. The next step generally in a microvascular decompression is when you retract the cerebellar surface from superior down. You will see the 5th nerve, you will see the superior petrosylvane, and you'll see the 7th, 8th nerves at the lower end of your craniotomy, and all in their own arachnoid sleeve. So you should not open the other arachnoid sleeves. You should just open where you want to go. And this is what you would see. You will see the trigeminal nerve in the depth. Now, I have seen, and unfortunately, I get to see some of these trigeminal neuralgias, which have been operated at other centers by sometimes younger neurosurgeons, who mistake the 7th, 8th complex for the trigeminal nerve. And it is so easy to see because it is the most posterior plane. the fifth nerve lies much more anterior. And that is something people have to remember, that the fifth nerve lies much more anterior to the seventh, eighth nerve complex. The second indicator is you must see the superior petrosal vein in your field for you to identify the fifth nerve. So please remember that. And then, of course, with meticulous dissection, the artery is moved away. Now, I use autologous muzzle bits. We have used Teflon, but I have found it not very user-friendly, and somehow I've never got around to being happy with it. So I've used in my 400 plus cases, used autologous muscle, and I've been quite happy with this. So this is how basically the microvascular decompression happens. So this is a video showing the microvascular decompression. And like I said, you must see the tentorium and the posterior petrosal surface. Magnification is very important. You let out CSF, let the cerebellum fall. Let the cerebellum fall. And here you will see this is the seventh, eighth nerve, and this is the trigeminal nerve. So do not mistake one for the other. Keep this arachnoid intact of the seventh nerve so that you are sure that you will not injure the seventh nerve. Very often the injury to the nerves happens because all the arachnoid is opened and invariably some traction somewhere and the nerve gets injured. Now, technical difficulties arise because of the size and position sometimes of the superior petrosal vein, anatomy of the posterior petrous surface, and of course, anatomy of the compressing vessels. Now, in this, you will see what happens. We have a large sinus, which is not allowing us to open the dura right up to the corner. And sometimes when we make these small cuts, we open up the lateral end of the sinus. And important thing is that one needs to control that. This is a very clean surgery, and therefore one should not have blood going into the cisterns. So what I now do is use these small Liga clips, which are micro Liga clips, and occlude the lateral end of the sinus, use topical hemostats alongside that, and then you're good to go. But remember that these have to be placed in such a way that it does not come in the way of your instruments. Otherwise, just when you are dissecting the arachnoid of the cistern, you'll have venous blood pouring in, and that will make your surgery very, very messy. The surgery needs to be very, very precise and needs to be done through small corridors. It is not good to have very, very pulling or pushing techniques. This is not good, and therefore you have to be very, very gentle. Sometimes when you open up the dura and enter, you see the superior petrosal vein right in the center of where you want to go, and there is a thick arachnoid. So the arachnoid has to be opened. The superior petrosal vein has to be skeletonized. And sometimes even when you do this, you see that the trigeminal nerve is completely covered and you're not able to see anything. So you would have to do a lot of venous arachnoidal dissection. And this is where I think young neurosurgeons need to go to the lab. They need to practice and in the lab doing dissection. And this is very, very important. Microsurgical dissection is the key to a good surgery, whether it is aneurysm surgery, whether it is acoustic surgery, whatever it is. I think arachnoidal dissection is the key. And one needs to be able to do fine, delicate arachnoidal dissection, sharp dissection, so that one can release the superior petrosal vein, create space as one goes along so that one can get between. So you see now you're seeing almost the dress of the fifth nerve between the branches of the superior petrosal vein. And that is very, very important to do. And one should be aware that sometimes this is a position where you will be. And now you have to work between the two branches of the superior petrosal vein to do this. Without doing this dissection, it would be impossible to reach the pathology. Now, occasionally what happens, this is the same continuation of the same video, and here you have got the dissection of the superior petrosal vein. But what I want to show in this video is sometimes what you see first may not be the actual pathology. And you would have to be, remember Janeta's statement, the surgeon has to be adept at identifying all the vessels involved, not only one vessel. So it can be more than one vessel. So what you're seeing here is one vessel placed dorsally, but there is one more vessel placed anteriorly there. There you can see the loop, which is going anterior to the nerve and causing an indentation. And that's actually the pathology. And one has to operate under high magnification. Occasionally, when one is unsure, the endoscope must be on standby. You use the endoscope and see what you're doing, and you must need to release all the nerves. So my technique is to displace the nerves completely and do the transposition technique. And this is very, very important. You must take your time, understand what is happening to the anatomy of the vessels, and then only place these small bits of autologous muscle so that the vessel is moved away completely. Remember, when you move these vessels away, there must be no kink in the vessel. Otherwise, you will create an ischemic area post-surgery. So that is also something which must be looked into, that there must be no kink, and this is towards the end of surgery. And this is the second vessel which you see first, and that too sometimes would have to be taken care of. If you're not sure, it is better to dissect that and then put a graft between that and the nerve. And that is what is being done here. So this is all has to be done very gently and delicately. Sometimes as soon as you open, you see large vessels like this. And this vessel seems to be the one which is indenting the nerve. And you see that there are a lot of arachnoidal adhesions. Now remember, all the artery has to be completely freed. And then you can see the severe indentation caused. You can see that the nerve almost has a concave surface. But then this is not the artery alone. And then when you dissect further, you then see there is one more vessel which is going inside and really invaginating the nerve. Remember, these small perforator vessels, there should be no traction. And you must be very, very gentle. Like I said, no pulling, pushing. There must be, it must be very gentle movement under high magnification and slowly ease the artery out. And that is something which must be done with a lot of delicacy, because these are all normal vessels. There is nothing abnormal here. So you must pay respect to each of these structures. So you sometimes would have to go between the perforators and try to release the vessel. Now we have released the nerve completely now, and then you now place the autologous muscle bits. The key to a successful microvascular decompression is to see the anatomy completely. And without doing that, you will not be able to get a good result. So once we have ensured that the vessel loop is never going to come back, you then have to ensure that what is even inferior. So there is a small vessel inferiorly here. So you have to pay attention to that as well and ensure that no vessel is in direct contact. So now the arachnoidal dissection has been done of that, and then the vessel is away, and then you place the graft in the right position. Sometimes you have large vessels, doliectactic vessels, which have to be dissected. And this is sometimes the most difficult part of a microvascular decompression, because these vessels will not, this is the superior petrosal vein, which has been dissected. That is the superior cerebellar artery loop. But the main indenting vessel is this large vessel that you see that I'm just now pushing away. And once it is pushed away, you then have to ensure that it stays away. And that is very, very difficult because the vessel is a large vessel. It is a heavy vessel. So it is difficult. And therefore, there have been many techniques described. You have slings which are described. Look at the size of the vessel compared to the nerve. Therefore, you would have to ensure that, you really make sure, and this is, you would have to go on both sides of the superior petrosal vein, ensuring there is no traction on the vein, but make sure that completely the nerve is free. At the end of the day, that is what would have to be done. Now, sometimes in this situation, all that you can do is an interposition graft. And this is something which would have to be done. And this is what was done for this case. This artery, which is inferior, is also taken care of, and that is at the end of surgery. One important point which many of us forget to look at is the suprameatal petrous ridge. Now, this is the suprameatal petrous ridge, which you would see on CT scans, which is just above the porus trigeminatus, where the trigeminal nerve exits the posterior fossa. If it is more than 3 millimeters, it is significant and it can cause a problem during surgery. Now, this was a patient who came to us with severe trigeminal neuralgia. And look at this. This is the suprameatal petrous ridge, which is there, which is hindering the view of the rest of the trigeminal nerve. You can see that this is the offending vessel, but you can't really see the rest of the loop. So in order to get that, now this is the, you can see that this is the ridge and this is the nerve. So this is actually abutting the nerve. So you would have to get there. So you would have to drill this suprameatal ridge. Now, I normally put even in acoustics or other things, put a small piece of gel foam inside so that the bone dust does not settle onto the structures deeper. You need to use a small diamond head. Be very careful because there is no space for maneuvering. The superior petrosal vein is above, the 7th, 8th nerve complex is below, and therefore you gradually drill the suprameatal ridge till you are actually able to see what you are doing, and you can see the entire loop. So once you drill more and more, there is no problem drilling here, except the fact that you have to be very, very precise. So microvascular decompression surgery is not a simple surgery which you can take lightly. It is something which requires a lot of practice and experience and knowing what to do when the situation demands what you have to do. And now that we have drilled that meatal ridge, we are now able to do the surgery. Sometimes it's a vein which is causing the compression. And here you would have to dissect that vein completely and then have to, so here the vein has been completely dissected and the muscle placed between the vein and the nerve. Glossopharyngeal neuralgia presents its own problems. This is the view that you would get when you start the surgery. So you would have to see the choroid plexus, and then you would have to look for the vessel, which is sometimes can be anterior. In this particular case, it was a large vertebral artery which was taking an acute turn, and that's the vertebral artery which is compressing the nerve, and that would have to be dissected away. And that has to be completely dissected away very carefully.
You have 1 minute to summarize.
Okay. So this is the this is the vertebral artery, and this is sometimes can be difficult. So Tinnitus and disabling positional vertigo is something which people do not look at because the results are variable. Success is seen in up to 75 to 80% and needs a complete audiological evaluation, and intraoperative monitoring is very, very necessary. This is what you would see. I will just show you some of the cases that we have done. This is how it is done. And you have to be very, very careful. And as you would see in this particular patient, you can sometimes see a large vessel going between the facial and the cochleovestibular nerve, which requires very fine dissection, and you have to make sure that the job is done. Of course, facial nerve monitoring is needed, and you would have to do what is necessary. You would have loops going around. Orientation of the cochleofacial nerve complex is difficult. I will just keep moving on. Redo MVDs are very difficult because it is really a lot of tough dissection because everything is stuck. And therefore, the first time you do the surgery is the best time. So redo surgeries require a lot of time and a lot of very, very difficult dissection. So the complications of MVD are most often avoidable, and one must maintain strict microsurgical and anatomical principles. And very good microarachnoidal dissection techniques are vital for good results. Young neurosurgeons must practice, and that is the most important key to good microsurgery. So thank you very much. Thank you for your patient listening.
Thank you, Sridhara. Very wonderful presentation. Thank you for keeping on time. I think Prof. Sridhara has demonstrated his elegant technique. I only listened preservation. I never heard the word sacrifice. So it's all about anatomy, delicacy, respecting the vessels. You have to find all the offending, conflicting vessel, artery, vein. And he also demonstrated a very nice technique, including managing complication right from opening, and then when you can have a bleeding, for example, from the sinus. And he also demonstrated us from fresh case to a redo case, and as well as his technique of using the autologous muscles. I believe that there are many questions, but we cannot discuss live because plenary, we have to be on time. But you can write in the chat box, and subsequently, I hope the speaker will respond to the question. So now we shall move to the third and the fourth presentation. It gives me a great honor and pleasure to introduce Professor James Liu from US. Hi Liu, how are you?
Good, how are you?
Very good. So it is an honor and pleasure to welcome you to the second ACNS International Virtual Conference. So Professor James Liu is from United States of America. So he is the Director of Surgical Neuro-Oncology and the Brain Tumor Center, Center for Skull-Base and Pituitary Surgery, and also Director of the Cerebrovascular Bypass Program, and co-director of endoscopic skull-base, and from the University Hospital, New York, Jersey, United States of America. And Professor James Liu, I think very popular in webinar. I think almost every alternate night and every week he will appear everywhere. So thank you for your kind support, especially for educating a young neurosurgeon. So he will have 2 lectures. Yeah. So he agreed to take a marathon lecture. So his first lecture will be on acoustic neuroma, maximizing extent of removal of facial nerve preservation. And that will be followed by his second lecture of Endonasal Approach for Craniopharyngioma that he bring forward from tomorrow lecture. Yeah, Liu, am I right?
Yes, correct.
Okay.
Thank you.
Thank you very much. So the podium is yours. Please continue.
Okay. Allow me to share my screen here. Can you see my screen?
Yes, sir. Yes.
Okay, great. Well, thank you, Azmi, and thank you, Professor Rohadi, and the organizing committee for ACNS. It's a real honor for me to be here on this webinar series, and and to present here at the ACNS. And hopefully someday we will meet in person in Indonesia, and that would be very exciting one day. So I'd like to talk about my first lecture here is acoustic neuroma. And as you know, one of the major treatment objectives in acoustic neuroma surgery is to try to remove the tumor all of it as much as possible, but also to preserve the facial nerve function, because this plays a significant role in quality of life. Now, in recent years, there's been an increased interest in this concept of adaptive hybrid surgery. And what this is where the surgeon plans a subtotal resection followed by gamma knife radiosurgery in order to improve facial function. And what this has resulted is, in this commentary, is that it's now resulted in some increased non-specialty centers with less experienced surgeons attempting to perform these acoustic neuroma surgeries. And so let's take, for example, this is one of my own patients. This is a 40-year-old woman who had this large acoustic tumor, and she was operated on by someone in the community where they took a very small decompression, barely touched, and then treated it with radiation, and they told the patient, we got most of it, but the rest is inoperable. What happened to this patient was she became spastic quadriparetic. She was almost in hospice, but fortunately she was referred to our center for a second opinion. And so she had previous retrosigmoid surgery, so my plan here was to come in translabyrinthine. And because of the strict adherence of the tumor to the facial nerve and prior radiation, I had to leave a cuff of the tumor along the course of the facial nerve. And this is her scan here at 9 years later, and you can see she went from being spastic quadriparetic to ambulating, and then here she is almost 10 years post-op, doing well with a normal quality of life. So if you look at a recent systematic review of this subtotal removal with radiosurgery, they call this a nerve-centered approach, meaning that it's focused on preserving the facial nerve. But if you critically analyze the reports, all of these studies, the subtotal removal is all intracapsular, meaning there is no attempt to come around the tumor in an extracapsular fashion. And although the tumor control rate and the facial nerve function looks very favorable, the follow-up is rather short. And although these results look favorable initially, we must ask ourselves, is this the best thing to do for the patient? Some of my own personal criticisms about this approach are the subtotal removal is already pre-planned, which means as the surgeon you are saying, I'm not going to even try. And the debulking is primarily intracapsular, so it's always difficult to assess how much tumor is actually left behind, even with image guidance. And so you can end up with a huge spectrum of subtotal volumes. And I must say that not all subtotal resections are created equal, and I'll show you why. It's lacking long-term follow-up, and we have to ask ourselves what's going to happen in the next 10 to 20 years, and will we be treating an emerging disease 1 or 2 decades from now? And as professors and teachers, we have to ask ourselves, well, if the teachers are not doing high-level microsurgery, then how are we going to be training our future trainees, our residents? And who is going to perform the difficult microsurgeries of not just acoustic neuromas, but other posterior fossa and petroclival lesions, if the teachers are not performing them anymore? And so I think just what Professor Kato said about aneurysm surgery, acoustic surgery, I think will slowly become a lost art. So does it matter how much you leave behind? If you look at the literature, it certainly matters, and it shows that extent of resection does matter. The volume of residual tumor is proportional to the rate of recurrence. So not all subtotals are created equal. This is my own classification where If you leave more than 5% behind, this is called the chunk. And if you leave a thin thickness on the nerve, this is the carpet. And then if you leave barely any visible linear enhancement, this is what I call a near total resection of 99%. So how can we achieve maximal tumor resection, but yet still achieve the best facial nerve outcomes? My own personal strategy and philosophy are the following. I think you must go into surgery with the intention that you're going to try to remove all the tumor in a curative fashion. And your decision to leave residual tumor behind should be based on intraoperative findings and judgment that you make based on the observations at surgery. For example, if the tumor is adherent to the facial nerve, you make a judgment and you leave the least amount of residual while preserving facial nerve function. And this will allow you to maximize the extent of resection, in effect achieving a radical near total or radical subtotal removal. Now, one of the techniques I find very useful is this one that was described by Sasaki in 2009. It is called the subperineural subcapsular plane of dissection. And if you look at the diagram from his paper, you can see that the tumor is enveloped by the vestibular nerves, and the stretch of the vestibular nerves creates this thin membranous fiber called the perineurium. And the perineurium that you see here looks like a clear membrane, and often people will mistakenly call this the arachnoid plane, but this is truly not arachnoid. It's stretched perineurium of the vestibular nerve. And the advantage here is that this perineurium creates a buffer of protection over the cochlear and facial nerves. So your plane of dissection is between this layer and the facial nerve. You do not want to be dissecting on the facial nerve directly. And so I often will use the concept of peripheral nerve surgery, where it's like onion peeling. You find the perineurium over the true tumor capsule, and you slowly undress the tumor by peeling it like an onion, peeling the vestibular nerve fibers and perineurium around the tumor capsule, so that you leave that perineurium as a holy veil or a buffer of protection to protect the facial nerve. So do not dissect in the subarachnoid space if you don't have to. You want to remove the tumor so that at the end it looks like a glove. So here's a video example showing this technique. This was a 1.5 to 2 centimeter tumor. We did a retrosigmoid approach here, and I often will drill the IAC first because this gives you early detection of the fundus, and it gives you the same advantage of a translabyrinthine approach with early identification of the facial nerve distally. It's important to debulk the tumor and collapse it, and so now we're identifying this perineurium, which is this clear membrane that you see here. We can now work around the medial side of the tumor and peel the tumor away from the brainstem. You can see there's this clear membrane. This is the perineurium of the vestibular nerve, and you can slowly dissect in this plane, peeling the tumor capsule away from this perineurium. We now pick up the plane on the top side of the tumor, and now we can now peel the perineural plane off of the IAC, and I'll use this McIlveen knife to release the last portion of the tumor, and then slowly dissect the remainder of the tumor here using this sharp dissection technique. And so here's the final removal. You can see it's like a glove. The perineurium covers the facial and cochlear nerves like a glove. It stimulates at 0.05 milliamps, and we'll use an endoscope to look to make sure there's no air cells. Immediately post-op, he was a Brachman 2, but recovered to a Brachman 1 in less than 6 weeks. So this was a very nice result. Here's a much larger tumor. You can see this was a greater than 4 centimeter acoustic, significant brainstem compression with hydrocephalus. Here we've debulked the tumor and we've identified the lower cranial nerves. I'll use a sharp dissection to spread along the tumor to find the vesicular nerve and slowly peel it away from the tumor. This is the perineural plane, and you can see it's like peeling an onion off of this tumor, and then you slowly continue to work in this plane using sharp dissection. And I often will use this scissors technique where it's like a slight push of the scissors and a suction sweeping technique to continue to peel that perineural layer away from the tumor capsule. There's the trigeminal nerve on the top side of the tumor, and here we've gotten into the subarachnoid space a little bit, but then you can redefine your plane, find the perineural layer on the superior margin of the tumor, and look at this thin membrane. That's the facial nerve behind this clear membrane. I call this the holy veil. It's a nice thin membranous fiber that prevents you from touching the facial nerve directly, and this really preserves the vascular supply of the facial nerve, allowing you to get better preservation and function. And then we'll continue to peel this perineurium away from the tumor capsule, slowly peeling it, and then using sharp dissection wherever the tumor is adherent to the perineurium. And on these large Coos grade 4 tumors, I have a very low threshold to just incise and trim and leave a little sliver of tumor attached. You can see there's a little residual here. It's adherent to the perineurium that's overlying the facial nerve, and the facial nerve stimulates great at 0.05 milliamps. And this is him immediate post-op. He's got a House-Brackman grade 1 for a large tumor like this. This is a near total removal. I left a very small microscopic adherence to the nerve, and he did wonderful from the surgery. You can also apply this technique on a translabyrinthine approach, and I'll often use a translab approach if there is significant brainstem that is wrapped around the back of the tumor. So I don't want to retract the tumor and retract the brainstem to get to it. So in these cases, when the hearing is already impaired, translabyrinthine is an excellent option. So we're working in the presigmoid space. We're using a fine micro bayonets to spread and identify that plane between the tumor capsule and the brainstem. And then using sharp dissection, we can define that subperineural plane. You can see the clear membrane beginning to show itself, and any arachnoid adhesions of the tumor capsule to the perineurium we can incise, and then use a fine microbayonet to use a gentle spread technique to spread the tumor and peel it from the perineurium in this fashion. Now we're going to work in the IAC. Here's the facial nerve at the distal end of the IAC. I'll often use a round knife or a Roten disc dissector to gently push away the nerve away from the tumor capsule. And it's a very nice technique to work in that fundus and IAC portion. And oftentimes the tumor will be very adherent at the area of the porus acousticus. So in this region, I often will create a pseudoplane and leave a little thin remnant of either tumor or vestibular fibers stuck to the perineurium at the porus acousticus. You can always come back to that area and remove the rest later, but in the beginning I usually like to release it so it's free from the facial nerve. And again, this is the last part of it. You can see we're dissecting the perineurium. Here we're trimming and leaving this little microscopic residual. This is the part that's most adherent that I was describing. And then using this sharp dissection, we'll release the last portion of tumor. We'll stimulate and look for the facial nerve along the brainstem. And you can see if there's some microscopic bleeding, I'll let it bleed, and I don't use cautery here, except in this case, this is just a small branch, but I don't use cautery on the perineurium because this can cause facial nerve injury. Little gentle Surgicel is excellent for hemostasis, and the facial nerve stimulated at 0.05 milliamps. And this is the repair technique that we've described. The traditional technique is to plug this presigmoid dural space with a fat, but oftentimes on the post-op MRI you'll see fingers of fat pushing on the brainstem. So I like to use this fascial sling technique, where you suture the fascia in an interrupted fashion, creating a hammock or a sling, and then putting the fat on top, and then it creates this nice nest, if you will, to hold the fat graft, and then we'll bolster the fat graft with this MedPort Titan plate. And this is very effective in preventing CSF leak. And you can see this is the patient immediate post-op, radical near total with a Brachman 1. And here's some other examples of large tumors. These were near to gross total. All had Brachman 1 facial nerve outcomes. And then larger Coos grade 4 tumors. These are all near total. And you can see excellent Brachman 1 and 2 outcomes. And what we've seen is that we're getting more Brachman 1 and 2 outcomes. And if they do have some weakness initially, Brachman 3 or 4, we're seeing much faster recovery to a Brachman 1 and 2 as early as 6 weeks rather than 12 months. So this is, I think, a game changer. Here's a recent case we did last week. You can see this was a 5 centimeter acoustic. We did a near total removal, and you can see she stimulated at 0.05 milliamps. She was a Brachman 2, and I anticipate that she will progress to a Brachman 1 in probably 4 weeks. This is an example of a Brachman 3. This is one I did some years ago where I probably would leave a little bit more residual tumor, but you could see there's a little bit more disfigurement upon forced smile, and so this is an example of a Brachman 3. These are our facial outcomes in our last 95 patients using this technique. You can see 95% of patients had excellent facial nerve outcomes, with only 5% having moderate outcomes, and we did not have any poor outcomes of Brachman 5 and 6. You can see the majority of our tumors were large ones, Coos grade 3 and 4. And if we break it down into small tumors versus large tumors, you could see our Coos grade 1 and 2, we had 100% Brachman 1 and 2, and the larger tumors about 92% Brachman 1 and 2. So there was a slight decrease in the number of Brachman 1 and 2 outcomes with increased tumor size, but not by much. And what we also found was that the increased rate of near total and decreased rate of gross total increased with tumor size and grade. And this is not surprising, because this is just a reflection of the surgeon having a lower threshold to leave a little bit of residual on these larger tumors in order to get a better facial nerve function. And there did not appear to be any impact on facial nerve outcome whether you had a gross total or near total. And what was the recurrence rate? We had a 1.4% recurrence, which we treated with radiotherapy, and the remainder of the patients got yearly imaging follow-up. We did have a number of complications. We had 2 retrosigmoids that had cerebellar edema from, I think, excessive retraction, a couple of graft site wound complications, and 2.7% pseudomeningoceles that required a shunt, but no incisional rhinorrhea or otorrhea leaks. And I think our CSF leak rate is largely contributed to these repair techniques which we have described. We'll use a fat graft over the suture line and push it down with a MedPort plate, and I think this is very effective to preventing any pseudomeningocele and retrosigmoids. And this is the fascial sling technique we use for translab approach. So if we compare my own series with the meta-analysis that I showed you with the hybrid approach, you could see our facial nerve outcomes are very comparable. Of course, we have a much higher rate of gross and near total removal, and our usage of radiosurgery is far less than the 100% used in the hybrid approach. And I think I can make the argument that my approach to this is also a nerve-centered approach. And so, in conclusion, I believe excellent facial nerve outcomes can still be achieved while attempting maximal resection of acoustic neuromas. The subperineural technique is an excellent method that provides a buffer to protect the facial nerve, and the decision to leave tumor remnant should be based on intraoperative judgment as opposed to preoperative decision. And this approach can be nerve sparing, and we have to continue to raise the bar of these microsurgical techniques and to teach them to our future generations of neurosurgeons. Thank you very much.
Thank you, James Liu. I think I learned a lot from your presentation. I like the way you classified your surgical outcome and the way you treat, the acoustic neuroma. I'm sure there will be a lot of questions, but we will ask them to write in the chat box. Later, if you find time, maybe you can answer that. So can you continue with your second presentation, because you are perfectly on time? So
yes.
On endonasal approach to craniopharyngioma.
Yes, I will share my screen now. Okay, can you see that?
Perfect, very clear.
Okay, terrific. So thank you for accommodating the time zones here to allow me to present back to back. I'll begin with craniopharyngiomas. That these are very challenging tumors, very difficult in a deep location, very intimate relationship with very critical neurovascular structures. We know that these craniopharyngiomas come in a lot of different shapes and sizes, and not every craniopharyngioma is the same. Each case has its own unique features, and our goals of surgery should be a radical gross total if safely possible. We have to optimize quality of life, preserve the vision, avoid injury to the hypothalamus, and if possible, we try to preserve the stalk, but that is not always the case. So what is the best approach? Should we be coming from above or from below? And we wrote this paper some years ago about the how to choose the optimal surgical corridor to using a personalized, tailored approach. And I think when we select the approach, we have to look at tumor location, extent of pathology, tumor consistency, the relationship of the optic chiasm and the pituitary stalk. Is it pre-infundibular, post-infundibular? Do we have a pre-fixed chiasm or a post-fixed chiasm? Is the tumor pushing the ventricle floor upwards, or is the tumor truly a intraventricular tumor in the third ventricle? And of course, does prior surgeries factor into the decision? And surgeon's preference and comfort, I think, ultimately factors into the decision. So this is Kasam classification, which I find very useful. Type 1 is the pre-infundibular, and these are the ones I feel that you can save the stalk in most cases. The type 2 expands the stalk, and in these cases you cannot really preserve the stalk, and will often transect the stalk at the base right above the gland in order to release the tumor. And retroinfundibular can be very difficult because the stalk is in your way. And of course, recognize the purely interventricular types, because this may require a transcranial, transventricular approach. And so you can classify these approaches into midline, frontal, anterolateral, and a lateral approach, such as the combined petrosal approach as popularized by Hakuba and Professor Kenji Ohata. And so when I first started doing these craniopharyngeal surgeries, I was doing them with an open approach. This is an example of one of my very first craniopharyngiomas about 15 years ago. You could see it was a large tumor going up into the foramen of Monroe. And I did this through a Transylvian approach, and you could see you do not see the tumor because this is a very prefixed chiasm. So in order to visualize the tumor, you had to open up the lamina terminalis and then work in between these small corridors between the carotid and the optic nerve. So these can be very challenging because you have blind spots and there's a lot of neurovascular manipulation. And if we had to do this through an open approach, you could see if you come in directly midline, there's some advantage of a midline approach. You can have equal access to both walls of the third ventricle as opposed to an oblique anterolateral approach. And one thing I always like to look at is the position of the chiasm and the lamina terminalis window. So here you can see the infrachiasmatic window is quite narrow, and the lamina terminalis corridor is much bigger, and the tumor does not really present itself to the infrachiasmatic space. So endonasal on this I think would be very challenging. So in this case I chose a lamina terminalis approach through a frontobasal interhemispheric approach. Here's the video demonstrating the opening of the lamina terminalis, and then we access the tumor, and from here we can deliver the tumor and bring it downwards into the lamina terminalis corridor, and we have equal access to both walls of the third ventricle and hypothalamus. And you can see here a nice removal. There's the basilar artery, and although the we have to remember that when we do an approach from above, there's a blind spot, and the blind spot is on the undersurface of the chiasm. And so although the initial post-op MRI looks very favorable, you must follow these patients because craniopharyngiomas are notorious for recurrence, either early or in a delayed fashion. You could see there's already some recurrence, and this is largely from that blind spot that I had mentioned. So this was successfully treated with radiotherapy, and he's been under control for a number of years. So what is the best approach? To come from above or to come from below? And you could see the different views of the retrochiasmatic area, looking from above or below. And I think the major advantage from coming from below is that you have this ability to visualize the undersurface of the optic nerves and optic chiasm and the hypothalamus. And this is an area that you don't see very well from above. So look at this beautiful view at the hypothalamus underneath in that retrochiasmatic space. Here's an example of a craniopharyngioma that's supradiaphragmatic. You have to choose the correct approach. I think younger surgeons can often mistake in this and use a transcellular approach only to biopsy the normal gland, but you must come supradiaphragmatic through an endoscopic transplanum transtubercular approach. So what are the operative pearls for success? We often will use a 30-degree angled endoscope that allows us to look upwards into the ventral skull base. When you drill the planum sphenoidale, remember that it's not a rectangular bony opening. It's actually trapezoidal because it follows the course of the optic nerve canal in a anterolateral fashion. Some people have described this as the chef's hat opening because it looks like the shape of a chef's hat. And so when we open up the planum, you can see it looks trapezoidal. We decompress both medial optic nerve canals, and when you open the dura, you have to look for these perforators that come off of the medial ICA. These are the superior hypophyseal artery perforators. They will feed the stalk, but also feed the visual apparatus. So if you coagulate these arteries, you will result in visual complications and possibly blindness. So be careful, preserve these small arteries. And when you dissect the arachnoid, dissect along the plane between the tumor capsule and the arachnoid membrane so that you are, just like the onion peel, you're undressing the tumor and mobilizing the arachnoid towards the ICA, the PCOM, and the PCOM perforators, and you're working directly on the tumor capsule. And this will allow you to preserve these neurovascular structures. That arachnoid membrane will continue along the floor of this tumor, which will be the membrane of Lilliquist. Preserve the membrane of Lilliquist because this will protect the P1 perforators. How do we find the pituitary stalk? I typically will look for the gland, which is on the bottom of the tumor, And if you lift the tumor capsule up, look for the portal striations, and in some cases you can find the pituitary stalk, and this will allow you a better chance to preserve it if it's anatomically favorable. And then here's the basilar artery invested in the membrane of Lilliquist. And in some cases you're not able to preserve the stalk because it's a type 2. And in this case, I agree with the editorial by Professor Oldfield that it's better to transect the stalk to get a gross total to prevent recurrence, and you can replace these patients with hormonal replacement therapy. So here's an example of a stalk blowout. I'll show you. This was here's the tumor. Here's the mammillary bodies being dissected from the undersurface of the chiasm. And then you can see this tumor was very adherent. These cystic tumors are often sometimes more difficult than the solid tumors because the cysts just collapse and it's hard to get a handle. Here's the base of the stalk. You see there's no plane with the tumor. The stalk is expanded. So here we'll do a low stalk transection in order to release and allow us to deliver the rest of this tumor. And you'll see that this tumor was quite adherent to the chiasm, so we'll trim it, leaving a little thin remnant adherent to the optic chiasm so we don't injure the visual apparatus. But you must use sharp dissection, two-handed microsurgery, and then this allows us to deliver the remainder of this tumor. And here's the view of the Ica Complex recurrent artery of Hübner and the optic chiasm. So this approach gives you that direct view of the hypothalamus. And remember, don't pull but yet deliver the tumor. So don't avoid that temptation of pulling early because you don't want to avulse anything. And then you get this beautiful view of the mammillary bodies, the posterior circulation, and the third ventricle. So reconstruction is always a challenge. These can be met with high risks of CSF leak. We often will use a multi-layered repair using autologous tissue with fascia lata and a nasoseptal flap. And you can see this is what it looks like. Here's a video showing reconstruction. You can see this is a large defect, so we'll use autologous fascia lata and then use a little bit of Surgicel to hold the fascia lata in place. We'll use a second layer of fascia lata, a little bit of Surgicel to hold it in place, and then we'll mobilize the nasoseptal flap. And it's very important to walk the flap down along the skull base. It's important that there's no nasal mucosa on the bone, as this will cause the flap to dehiss. And then once the flap is up, we can then bolster it with Surgicel and some gentamicin soaked gel foam pledgets, and then a Miracell packing. And so this is what it looks like in the office with my ENT colleague, Dr. Eloy, who will debride these patients. And you could see at 2 months, there's excellent mucosalization of the skull base. And this is what it looks like. You see how there's no T2 changes on the hypothalamus. The hypothalamus is nicely preserved, and this patient had excellent visual outcome. So it's important to choose the right approach. Again, this is a supradiaphragmatic tumor. This is not a sellar pituitary tumor. And so you have to go above the diaphragm with a transplanum approach. This is a patient who had the wrong approach. You see this open defect here. This was done by another surgeon who went transsellar and did a pituitary gland biopsy. So we took this patient for a transplanum transtubercular approach. You could see we now entered the cyst to decompress the cyst. And then now that the cyst is decompressed, we'll slowly dissect the tumor away from the chiasm. And so here the tumor is quite adherent to the chiasm, so you have to use sharp dissection to peel the tumor from the chiasm. And then this is the stalk here. You can see this is a pre-infundibular tumor. We were able to peel the tumor away from the stalk, and then use sharp dissection to eventually release this last component of the tumor. And there's the view of the third ventricle, and there's the stalk. The stalk was preserved in this case. Here's an example of a pediatric patient. This is a 12-year-old boy who presented with visual loss and panhypopit. He had short stature and obesity. So here we're doing a endoscopic transtubercular approach. We open the dura above and below the superior intercavernous sinus, and this allows us to get into that suprasellar space. And there's the tumor situated just in front of the chiasm. We'll go ahead and debulk the tumor using this side cutting aspirator, and then after decompressing the tumor, we can then come around the tumor in an extracapsular fashion. You can see we're putting a little gentle traction on the tumor and then using a suction dissector to carefully dissect the tumor from the undersurface of the chiasm. This is the view that you do not get from an open approach from above. I can see the hypothalamus, I can see that undersurface of the chiasm, so there's no blind dissection. Everything is done with direct visualization. We'll then lift up the bottom of the tumor looking for the membrane of Lilliquist, and once the tumor is completely freed and detached, you can then carefully deliver the tumor. Again, you don't want to prematurely deliver the tumor without fully detaching it. And then this is the final view. Using a 30-degree angled endoscope, we can look at the third ventricle. And then with the 30-degree scope, we can rotate the lens so that we can look in different angles without changing the scope. Here we're looking laterally to the left. You can see here's the ICA exiting the distal ring. And then here you can see there's the pulsations of the membrane of Lilliquist that's been preserved. And then there's the defect that is being reconstructed. Here's the post-op scan, complete removal, excellent decompression of the chiasm. And this patient's been recurrence-free for almost 9 years. Here's another child I did. This was when I was visiting professor in Mexico City. We did live surgery here with some of my colleagues. You could see we got a gross total removal, and she's been 2 years recurrence-free now. So can we do endonasal approach even if the patient had a previous craniotomy? This is a patient who's had a recurrent craniopharyngioma. She's had 3 prior craniotomies, 1 microscopic transsphenoidal, and had a previous right ICA injury, and she's blind in the right eye. And this tumor continues to recur. Why? Because the cyst wall has never been removed. And so if you look at this cyst wall, should you do this from above or below, look how it presents nicely to the sphenoid sinus. So naturally here I would choose an approach from below, endonasal. And so what we'll do here is we'll drain the cyst, and you can see, look at the cyst wall. It's very thick, it's very fibrous. You can stop here and just allow the fluid to maybe drain into the nose cavity, but we're going to try to remove the cyst wall here. So luckily we found a plane. There's the left optic nerve. That's the remaining optic nerve that she has left that she's able to see, so we must preserve that. And then you can see this very thick capsule is difficult to remove, so we'll use a side cutting aspirator. And then I left a very small residual along the wall of the cavernous sinus. I didn't want to cause an ICA injury. And you can see this was a near total removal, and I treated her right cavernous sinus with IMRT radiotherapy, and she's been recurrence free for almost 7 years. This is a recent case we did, very large craniopharyngioma. She presented with mental status changes, hydrocephalus. The tumor goes all the way up into the foramen of Monroe. And in this case, you can do above or below, but here I chose endonasal approach. So endonasal approach can even remove these large giant tumors. And you can see the tumor is collapsed. And the reason is I can come in here and I can visualize this hypothalamus. And oftentimes what you'll see is the hypothalamus has this very, the tumor has this gelatinous appearance where it's very adherent to the hypothalamus. And so you can find this interface by using sharp dissection and slowly peeling this gelatinous neoplastic material off the hypothalamus. And you can do this safely with this type of dissection technique. And so after you release the tumor, you can now deliver it. And there's the large tumor being moved after debulk. And look at the beautiful view of the third ventricle. You can see the foramen of Monro that are dilated from the hydrocephalus. And here's our final view, complete removal of this tumor. And she did great. She was neurologically intact and regained her function and was on hormonal replacement therapy. So what about this large tumor with a large cyst with a solid component? You can argue to come in from above, or you can come in from below first, or you can do even a combined approach. So those are all the different approaches I had contemplated. But in the end, I decided, because the solid component was the harder part, and it was retrochiasmatic in location, I decided to come in endonasal first and to see how much I could remove, and then to come in at a second stage from above if necessary. So here you can see we're opening up the dura in that planum sphenoidale area, draining the cyst of the craniopharyngioma, and then we'll go ahead and remove some of this solid component to initially debulk the tumor. And now we look for the supraclinoid ICA. Look at the small perforator here. We have to preserve this perforator. You have to use sharp dissection. This is not a tumor vessel, because that perforator will go all the way back to the chiasm. But look how this tumor wraps over the chiasm and then forms this frontal lobe cyst. You could see the cyst is already encasing the ACOM, it's encasing the optic nerve. So at this point, I've already made the decision in my mind that I'm not going to be able to remove the tumor radically. There's going to be some microscopic tumor left behind. And so in this case, if I can preserve the stalk, I'm going to try to preserve pituitary function here. So there's the pituitary stalk. It's coming right off of the gland. You can see here's the stalk going up to the hypothalamus, and you have to use sharp dissection. There's the basilar artery. There's the chiasm. And now we're going to be able to remove this solid component of the tumor. And then there's the frontal lobe cyst. So I cannot remove this. This is too deep. It's too adherent. The ACOM is encased by all this microscopic tumor material. But overall, I achieved my goal. I decompressed the chiasm, I preserved the stalk, and I did what's called maximal safe removal. I was able to preserve the pituitary function, and now I have an empty cyst wall. So at this point, I debated on coming from above to remove the cyst wall, but I knew that the cyst was encasing the ACOM, so I knew either way it was going to be a subtotal. So instead, I went ahead and irradiated the remainder, and look at 16 months post-radiation. That residual cyst wall has almost disappeared. And so we published this recently, showing this strategy of maximal endoscopic resection followed by early radiation therapy. So I think there's a role for radiation therapy for a radical sub or near total. Here's an example of a snowman-looking tumor. I was able to remove all of it with the exception of this area, which was hidden behind the ACOM complex. So it was wrapped around the perforators. It was too dangerous to remove. I watched it, but look, it's already grown at 3 months. So I subjected the tumor to radiation therapy, and look, at 2 years, it's already melted away. And here's another example of an 18-year-old who had a combined endonasal with IMRT radiotherapy with excellent control, 9 years recurrence-free. Here's an example of a 17-year-old male. This was treated by one of our colleagues with an Ommaya reservoir. You can see a nice collapse of the cyst, but Ommaya reservoir drainage is not a definitive treatment. These will recur, as you see here. So now that it's recurred, we underwent endonasal therapy. We got a near radical subtotal with a little bit of this residual behind, and then we radiated it, and the patient has been under control for the last 5 years. So I think there's a role for radiation therapy in subtotally removed tumors, and I think I want to address when the open approach is necessary. There are limitations to the endonasal approach. Look at this tumor going out laterally into the sylvian fissure, all the way up into the foramen of Monroe. Here we did a open transcranial approach, transsylvian. The patient is already blind in the left eye, and so the left optic nerve in a blind eye is often very atrophic. In this case, it blends with the tumor capsule. So in this case, you have the option of dividing a already impaired optic nerve. So there's the optic nerve, it's very atrophic, and because they've been blind for many years, we're going to transect it to get more space, and then this allows us to deliver the rest of the cyst wall from the retrochiasmatic area. Now, interestingly, I thought this was going to be a craniopharyngioma preoperatively, but histologically this ended up to be a Rathke's cleft cyst, and this is a total removal, and you can see post-op scan radical removal. I think you have to consider an open approach for this. This goes way lateral into the sylvian fissure, and naturally we will do a modified orbitozygomatic transsylvian approach. You could see this is the exposure, you could see the basilar artery, a near total removal here followed by radiotherapy with an excellent result. And then here's an example of an 80-year-old woman. She was having cystic recurrence after failing another Ommaya catheter, and so she was already treated at another hospital with a craniotomy, and she was blind in this eye on the left side because of her craniotomy. So now she has this progressive cystic recurrence. How do we treat this? It goes quite lateral, it goes into the frontal lobe, so I did not think endonasal would be great, but you can still do a minimally invasive approach through this eyebrow incision. So we came in through the right eyebrow, and you can see there's the cystic component, and what we did was we went transcortical to get the frontal lobe cystic component. So here's the frontal lobe cyst through a transcortical approach, and then we can dissect the white matter away from the cyst, and then we come in subfrontal into the subarachnoid space. There's the right optic nerve, and then we can dissect the tumor in the prechiasmatic space, carefully piecemealing the tumor from the prechiasmatic space. And this tumor was very adherent, so you really need to use a lot of sharp dissection to remove this tumor. And again, we'll do this in a piecemeal fashion, cutting it in small pieces. And then this is the part that was very adherent. This tumor was very adherent to the right optic nerve, but this arachnoid knife is very useful. This is an apex arachnoid knife. This is an AM22. You cut the fibrous adhesions on the tumor capsule, and it releases, and leaving those adhesions on the nerve. And so this allows you to land directly right on the tumor capsule and allows you to peel this tumor away from the optic nerve and avoid injury to the optic nerve. And so here's the reconstruction. She left the hospital in 2 days. Excellent recovery, and you don't have to worry about endonasal CSF leakage. And so there she is, and she was ready to undergo radiotherapy for all these recurrences. And lastly, I'll show you this tumor that's multi-compartmental. Look how it's encasing the A3s. And so when it encases the A3s like this, I come in interhemispheric, transbasal. You can see the cyst wall is wrapped around the A3s, and then you can see we got a near total removal of the tumor. And in less than 3 months, she came back to the emergency room with this large cystic recurrence, but this time the recurrence is in the retrochiasmatic space. So naturally we can come in endonasally remove that retrochiasmatic cyst wall, and you can see there's dense calcification stuck to the optic chiasm. There's the third ventricle, and she underwent radiotherapy, and she's been recurrence-free for the last 6 years now. So this was a nice result using both approaches. And lastly, I'll conclude with this case. I won't go into the video, but this was a patient who had a papillary craniopharyngioma. I got a near total removal. She has not recurred, but the reason why I talk about this is because we now know that papillary craniopharyngiomas are sensitive to BRAF and MEK target therapy. Some papers showing some good responses to papillary recurrences using BRAF inhibitors. Here's another paper showing excellent results with using this BRAF inhibitor. So this is an option that can be considered. So in conclusion, the endonasal approach I think is an excellent option for the majority of midline retrochiasmatic craniopharyngiomas. You really need to have expertise in both open and endonasal approaches and have knowledge of this anatomy and surgical technique. I think adjuvant therapy is also very useful, and I would advocate early radiation therapy if you know that you've left a residual. And of course, we have to continue to seek for molecular targets, as this can be a game changer in the treatment of these challenging tumors. Thank you very much.
Thank you very much, James Liu. Excellent lecture. I can't even blink my eyes in order to not to miss your critical video. Well presented, and you shows clearly that endonasal approach is one of the recent development for craniopharyngioma, because most of us, especially even the senior neurosurgeon, think that endonasal approach have a lot of limitation. And as we know, front transcranial, even you do interhemispheric, toroidal, there will be a blind spot, especially below the optic chiasma, as you demonstrated very well. And endonasal approach gives you a very nice wide view, and you can even metically dissect the tumor away from the critical structure that most of us probably still afraid and struggle to deal with. And you have shown a very good result. So thank you very much for your excellent presentation. We already have few questions in the chat box. Hopefully you can answer that. So we have to move to the next presentation because of time, and also thanks for keeping your presentation on time. Thank you, James Liu.
Thank you. Thank you, Asmi.
Right. So now it's my pleasure to invite the live speaker, Professor Binzu. Professor Binzu is also a very important person in ACNS. He is currently the co-chair of the educational committee. As you realize, they have in 1 week 2 webinars, and they have run more than 100 something webinar, already lost count. Yeah? So without stop. Yeah? So this is very excellent. And he also one of the executive editor of Asian Journal of Neurosurgery, and actively contribute to education and so on. And he's a professor of neurosurgery in Huashan Hospital, Fudan University, Shanghai, China. So it's my great pleasure to invite Professor Binzu to talk about current indication of EC-IC bypass. So Professor Binzu, the podium is yours.
Okay, thank you. Thank you, Professor Azmi, and dear Professor James, thank you for your nice presentation. And now I'm talking about the current indications of EC-IC bypass. The indications for EC-IC bypass include the blood flow replacement. Sometimes we use in the complex aneurysms, or square-based malignant tumor involving the vascular wall of ICA, such as nasopharyngeal carcinoma. The second type is a blood flow augmentation, including the moya-moya vasculopathy, or some chronic occlusion of ICA or MCA. So we can see how much blood flow can a high flow bypass supply. You can see this is a saphenous vein bypass. It can feed the whole hemisphere, even the contralateral ACA territory. This is after bilateral moya revascularization. We can see now the ICA, the both side of ICA was totally occluded. The whole hemisphere, the both side, was totally fed by the ECA branches, including the STA, middle meningeal artery, and the deep temporal artery. They are all branches of ECA. This is a long-term follow-up after the STA to MCA bypass. You can see the STA enlarged so much, and it can feed the whole hemisphere, even the contralateral frontal lobe. So the long-term follow-up even sees the whole hemisphere plus fed by the ECA in ICA occlusion case. So this is my personal record in bypass. Now I have already more than 8,000 bypass cases, totally in 110 hospitals in China and India. So before we perform the bypass, the tailored bypass for ICA, aneurysm, or malignant tumor, we should do the balloon occlusion test at first to estimate the natural collateral blood flow to guarantee enough blood flow replacement. For example, this is a pharyngeal carcinoma case. So you can see the tumor already invaded to both side ICAs. So for this case, we should replace the bilateral ICA blood flow. This is a preoperative balloon occlusion test for both ICA. We can see the ACA was quite patent. The ACAM is quite patent. So I do the one side ECA saphenous vein to M2 bypass plus STA-MCA double bypass. So this is the three stomas can give the whole brain blood flow replacement. So you can see after the bypass, the both ICA was totally occluded. Now the blood flow from the bypass vessels are very patent and abundant. Replace the whole brain blood flow. This is a vertebral artery angiogram. You can see the right side, which we didn't do the bypass side, can get some collateral flow from posterior circulation. So the circulated blood flow was enough. So for this kind of nasopharyngeal carcinoma case, I already performed 16 cases, all successfully replaced the blood flow of ICA invaded by tumor. And the ENT doctors completely removed the tumor soon afterwards. Now the patients are all good. For the ICA complex aneurysms, like this patient, the radiologist, they tried to perform the flow diverter implantation, but it's failed. So they sent the patient to me, and we can see preoperative balloon occlusion test showed little collateral blood flow from ACAM and the PCAM. So we should do the bypass. I do the STA-MCA double bypass, combined the ICA progressive clip. So I designed this progressive clip. At the first, we occluded around 70% of the ICA, then occluded the ICA in 7 days afterwards. Then we performed the angiogram again. You can see the ICA was totally occluded, and the double bypass of STA-MCA was all patent. So now we ligated the STA after 7 days. This is type 2 ICA no collateral blood flow from ACAM and PCAM. So the blood flow replacement should cover the whole hemisphere, including the MCA and the ACA territory. You can see the giant aneurysm, poor collateral from ACAM, and almost no collateral from PCAM. So I did the ECAS saphenous vein to MCA bypass combined direct ICA ligation. So normally the saphenous vein can replace the whole hemisphere's blood flow. So type 3, like this ICA aneurysm, the poor collateral A1 and PCAM, but we can see still some collateral flow from the A1 and the PCAM. So the blood flow replacement should cover the left MCA territory. This is a female patient. The STA is quite small. So I use a ECA to radial artery to MCA bypass combined with progressive ICA occlusion. So after 7 days, we totally occluded the ICA. Then you can see the blood flow from the bypass was quite abundant and covered the whole MCA territory. So this is an intraoperative video, and the blood flow 800. Type 4 IC aneurysm with good ACAM and the right A1, but the PCAM was quite poor. For this patient, the blue occlusion test, 20 minutes the patient can tolerate, but the 30 minutes the positive. So the blood flow replacement should cover the partial MCA territory. So this is a boy. His small is quite, his STA was quite good. So I use STA to MCA double bypass combined with the ICA progressive occlusion. This is the final result. You can see the double bypass was all patent, and the after the ICA occlusion, the aneurysm didn't show anymore in the angiogram. So this is a type 5 ICA aneurysm with cavernous sinus syndrome. The blue occlusion test was negative. CTP is also good, but the enhanced blue occlusion test, which means decrease the blood pressure about 30%. The patient have some syndrome immediately. So this kind of patient still need the still need the STM MCA double bypass. You can see after the bypass, we totally occluded the ICA immediately. The double bypass was all patent and supplied the partial MCA territory. Type 6 is for recurrent aneurysm. You can see this is a male patient, 50 years old, found the recurrent intracranial aneurysm 2 years after coiling and stenting. So this is a surgical plan. Actually, this patient already did one time open surgery. So we use original incision. This is a ECA radial artery to M3 bypass because we should replace the whole MCA territory. So this is the STA radial artery to MCA bypass combined with progressive clipping of right ICA. This is an intraoperative ICG. The blood flow was quite patent. For the even distal MCA aneurysm, we should also guarantee the enough blood flow replacement for M1 or M2 or M3, depends on the exact location of the complex aneurysm. So we published this article in World Neurosurgery. This is type 1 ICA to M1 segment giant aneurysm. So the replacement of the whole MCA blood flow, and we should protect the perforators of this segment. Balloon occlusion test was a positive. So we also use aneurysm trapping combined IC occlusion and the STA radial artery to M2 bypass. This is exact the clip position. This is another one, M1 aneurysm. You can see we did the proximal occlusion of the aneurysm combined with the distal bypass. So the bypass flow totally supplied the distal MCA territory. This is the unruptured M1 aneurysm with a thick wall. So this kind of patient, we can consider the distal occlusion combined the distal bypass. The blood flow replacement should cover the 2M2 segment. So this is a stoma, one in superior trunk and one in inferior trunk. After the bypass, we immediately perform the distal occlusion of the aneurysm. So just after 1 week, we can see the aneurysm didn't show in the CTA. This is type 4, even distal this is a M2 superior trunk big aneurysm. This kind of patient needed a long time to shaping the vascular cavity. So actually you can see after the surgery, I shaping the vascular cavity very well, but it need time to do so. So before we shaping the vessel cavity, I performed STA to distal M3 segment bypass. To this is a so-called protective bypass. Sometimes we can even resect the aneurysm and do the end-to-end anastomose in situ. You can see this is a partially thrombosed MCA, distal MCA giant aneurysm. We resected the aneurysm immediately and performed the end-to-end bypass, end-to-end anastomose. So this is another case. This is in the inferior trunk case. We performed the STA-MCA double bypass combined distal occlusion of the bypass. So afterward, the angiogram showed that the aneurysm was cured. This is a type 3 M3, even distal M3 big aneurysm. We can see this is a partially thrombosed MCA bypass. This is a quite large aneurysm comparing to the angiogram. You can see this is a very large aneurysm. So the aneurysm wall was quite thick. So we only distal clip the aneurysm and combine the distal STA M3 bypass. Intraoperatively, the MEP and the SCP monitoring is routine in every complex MCA aneurysm. ICG flow 800 is helpful in selection of recipient artery. Sometimes we performed in the hybrid operating room. Like this patient, we performed the angiogram immediately after the bypass. So the complications in aneurysm or malignant tumor bypass, no morbidity in ICA, giant aneurysm, or malignant tumor bypass. But we still have a 12% delayed in function in small perforators in M1 or M2 giant aneurysms. So this segment is still the most difficult aneurysm. No mortality case. For Moya case, we always performed the STA MCA bypass combined EDMS. It's all individualized, designed according to the anatomy of the 3 layers of vessels, including the scalp, STA, or post-auricular artery, or occipital artery. For temporal muscle, it's anterior deep temporal artery or posterior deep temporal artery. For the dural, is a middle meningeal artery. So we use all the 3 layers of the ECA branches. So this is a long-term follow-up. You can see all the 3 layers, not only the direct bypass, but also the spontaneous stomas come from the deep temporal artery or middle meningeal artery. So this is a combined approach for Moya treatment. So it's very important to keep the integrity of STA, deep temporal artery, or middle meningeal artery. So keep the integrity of deep temporal artery. We just dissect the temporal muscle from the screw like this. It's a monopolar, but we don't use electronic power. This is to keep the integrity of middle meningeal artery. So the dural flap was all designed according to the main trunk and the main branch of MMA. We can see this is a original picture of the spontaneous stoma come from the middle meningeal artery to the cortex. So we also protect it very well. This is very important. This is a MMA and the MMV under the microscope. We can see the MMV is quite like the sinus. So I use this way to hemostasis for the MMV. At the meantime, keep the patency of the MMA. So I call this Chinese spring roll technique. The stoma is located in ischemic area like this, but not the infarcted area. This donor artery is quite small. The diameter is only 0.4 millimeter, but the titer P is quite high. You can see the vessel is thin, like this. So if the delta P is quite high in the 800 flow, you can see the red T sign. So this means the bidirectional faster blood flow means the big difference of delta P. So this kind of bypass is sustainable. So left side is a 1 bypass, right side is double bypass. After the revascularization operation, we check the aspect, you can see the right hemisphere, the blood flow increased a lot comparing to the preoperative condition. So we measured the blood flows in different branches of ECA. You can see in the bypass under the ECA branch, it's all increased. And the blood flow in ICA and the basilar artery was all decreased. In the ICA, maybe decreased around half of the blood flow. Basilar artery around 20%. So for this kind of patients, because already existed the ischemic condition, so time is very important. For my personal series, the mean temporal occlusion time is only 13.5 minutes. This is a dissection STA or post-auricular artery or occipital artery from inner side of the scalp with small power monopolar. You can see it's very easy to dissect the STA in minutes. And I close the incision of a superficial temporal fissure like this. To avoid the necrosis of the flap. Sometimes even two-layer suturation, including the gallery and the superficial temporal fissure. If the scalp, if the sulcus is quite wide, I will fix it with a dural strip, like the right side pictures. So my technique is so-called the simplest bypass, only use 1 or 2 or 3 curved microtemporal clips. Don't need to sacrifice any branch of the recipient artery. And I never use rubber mat or silicone rubber tube. The interrupted suturing is enough and the square knot is enough. The stoma should keep oval shape as natural branches because in every natural branch, the shape is an oval shape. Sometimes we use a loop technique like this. The first stage is located to the toe, then the here. Then one side, 4 loops can make 5 stitches. Another side, 4 loops. So now the 12 stitches for the, so this can keep the time even shorter. So this is after the bypass, the ICG. This is a 4D angiogram. You can see the ECA branch supplied the whole MCA territory. After the operation, the CT perfusion, you can see the blood flow increased immediately. And this is a long-term follow-up. You can see the most of the hemisphere's blood flow come from ECA branches. So the bypass for atherosclerotic cerebral ischemia is also very good. So the first type is ICA occlusion. Couldn't be recanalized by CEA or stenting like this patient. The second type is the MCA occlusion without Moyamoya syndrome, like this. the superior trunk of MCA was totally occluded. The third type is the MCA occlusion with the Moyamoya syndrome. You can see the Moyamoya syndrome, the ACA was still good. The MCA was a Moyamoya condition. Now we have a new type. Some neurosurgeons, they want to perform the stenting in the stenosis of MCA, but actually this can accelerate the occlusion of the MCA. You can see the occlusion of the stenting and even cause the bleeding. This approach for the simple occlusion case without Moyamoya syndrome, I only did the ST-MCA bypass, sometimes use a double bypass. If the patient have Moyamoya condition, I always combined with the EDMS. So this is a long-term follow-up. You can see the double bypass was all patent, and the deep temporal artery and the middle meningeal artery was also feeding the hemisphere. This is a 4D angio after the Moyamoya syndrome. So now we have a MI-TAS examination. You can separate the ECA territory and the ICA territory. Now you can see the ECA territory covers almost the whole hemisphere's neocortex. So I created a new technique, so-called the minimal invasive direct bypass. For the distal MCA, if the patient's distal MCA network with good integrity, and which means early stage of Moyamoya, Suzuki 1 to 3 stage, sometimes even 4 or 5 still have MCA network. And most of the Moyamoya syndrome, in this kind of patient, the main feeder is STA after approaching. Many patients have a psychological resistance to large incision and the large bone flap, leading to continuous disease progression and even loss of the direct bypass opportunity in the future. This is a minimal invasive approach, means small incision, small bone window, and keeping here, like this patient. Before the surgery, we decide the donor and the recipient artery in the 3D angiogram. This is surgical plan. This is a real surgical view. You can see the recipient artery was almost the same in the surgical field. And the post-operative CTA, you can see the left MCA was supplied by STA. So this is a type 2. There's some distance between donor and the recipient artery. We use this curved incision. This is an intraoperative video. You can see the bone window is only 1.5 centimeter. After post-operative DSA, you can see the bone flap was quite small, and the STA now enlarged a lot. Now for this kind of new operation, I designed a new set of single-arm micro-anastomose instruments. So this is an intraoperative video. You can see use this single-arm micro-anastomose instruments. You got enlarged surgical field. And this is a very good in the deep anastomose. So this is after surgery, you can see the angiogram, the blood flow reflux to the M2 segment. Okay, that's all for my presentation. Thank you. Thank you, every audience.
Thank you very much, Professor Binju. Again, another excellent presentation. I always amazed with your series of cases. If I'm not mistaken, you hold one of the highest series of personal bypass, 8,000, something like that. Yeah. So, yes. So excellent, very good.
Thank you.
And Professor Binju also offer actually scholarship and trainees for young neurosurgeon who interested to join him. But unfortunately, probably we have to wait until the pandemic is over. Yeah. So, and Professor Binju and Professor Ying Mao will organize the 14th Asian Congress of Neurological Surgeon, hopefully next year in September in Shanghai. So we hope everything will get back to normal, so everyone can fly to Shanghai and we can meet.
That's me. Maybe in March.
Okay. All right.
It depends. Yeah, depends on the condition of the pandemic.
Okay, excellent. And they will also organize concurrently with the Nursing Congress, yeah, Asian Nursing Congress, together with that. So I think with that, I have to wrap up the session. So I must thank all four speakers, Professor Yoko Kato, Professor Sridhara, Professor James Liu, and Professor Binju for such an excellent, informative lecture that I think everyone, right from beginners to most senior surgeon, learn every second. So I also would like to thank the organizing committee for arranging this beautiful session. So now I pass over this plenary session 1 back to the Master of Ceremony.
Thank you, Professor Azmi, and all of the speakers. I hope the participants found this session very useful. This is the end of the first plenary session, and to all speakers, participants, moderator, I would like to ask to please turn on your camera so we can do a photo session. Thank you. Now we will have a 10-minute break before the next plenary session. During the break, we will have some information from our sponsor, Mercy Pharma.
NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger. All these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections. NeuroAid is a natural product developed according to international standards. Its neuroprotective and neurorestorative properties have been demonstrated in animal studies and cell cultures. NeuroAid has been shown to enhance the natural processes of neuronal repair, neuroplasticity, and neurogenesis through synergistic mechanisms of action. It stimulates the production of new neurons, increases the number of connections between neurons, and makes neurons stronger. All these facilitating fuller recovery. This study compares neuronal cells treated with NeuroAid to non-treated neuronal cells. At day 1, cell cultures were similar between the two groups. After 14 days, however, cells treated with NeuroAid show a higher survival rate and are healthier with better cell-to-cell connections.
Now we will continue the second plenary lecture that will be led by Professor Sri Maliawan, MD, PhD. Before I hand this over to Professor Sri Maliawan, let me share a brief background of Professor Sri Maliawan. He went to Udayana University for his medical doctor in 1982. Then he continued to pursue neurosurgeon at University of Erlangga in 1991. He then became a neurosurgeon consultant, specifically in pediatric of spine and functional in 2000. In 2005, he did his PhD and became the head department of neurosurgery in Udayana University. He has been the professor, head department of surgery and neurosurgery in Udayana University. He is also actively involved in professional organization as well as community services. Without further ado, please welcome Professor Sri Maliawan.
Thank you for introducing me, Mr. Ceremony. First of all, can congratulate to Professor Rohadi to run this virtual congress, second virtual congress, ACNS. It's very successful, a lot of participants, and I myself learned in this congress. Thank you again. Today, this session, the second session, we have 5 speakers. And every speaker has 30 minutes for presentation and lectures. And may I invite for the first speaker, Dr. Johnny Wahyuadi from Indonesia. Dr. Johnny Wahyuadi, are you there?
Yes, already.
How are you?
I'm fine. Already finished to look around the vaccination.
Keep help.
Keep help.
Dr. Rohadi is now the director of the biggest hospital in East Java, Sutomo Hospital. You will present Indonesian Neurosurgery Association, what should to do to anticipate the global medical services issue. Dr. Johnny Wahyuadi, he was graduate in neurosurgery in Unair, Airlangga University, and then has a doctoral program already in Unair, Udayana University, and you can a lot of activity already done by him. He's very attractive and have many new idea. Also recently regarding the COVID situation. Now the recent status is he is director of Sutomo Hospital Surabaya. Dr. Johnny, now now is your podium, please.
Thank you very much, Professor Maliawan. He's my senior, my teacher. Thank you very much. And Dr. Hadi, thank you very much for inviting me to speak in this very opportunity ASEAN Congress of Neurosurgical Surgeons. I'm sorry, I'm aware about this custom of Committee of COVID-19 in East of Java, because I already see about the vaccination of COVID-19 in Java Post. Today I have a presentation about slide about the how should we do to anticipate the global medication services, especially in neurosurgical field. And I want to express our opinion about that, and based on several references. Right? This is my curriculum vitae. Today I am President-elect of Neurosurgical Society and Governor of East Java. Lead me to the conduct of the Dr. Sutomo General Academic Hospital in Surabaya. And today I have a very challenging job in East Java COVID curative task force. According to the several references in the world today, we have 10 global medical issues, especially on 2021, according to WHO. First is build global solidarity for worldwide health security. The second, speed up access to the COVID-19 test. That's very crucial, especially in our country. Medicine and vaccines. Yeah. Today we have vaccination to all of the people in Indonesia, but the readiness of the vaccine is still a problem because we didn't produce the vaccine by our country. Number 6 is a fund health for all. The 4, tackling health inequities. 5, provide global leadership on science and data. Data is very important to make good decisions. 6, revitalize effort to tackle communicable disease. Yeah, communicable disease is still a problem in our country, also in the world. Yeah. Combat drug resistance it's a very important thing that we must aware about the drug resistance, especially antibiotic resistance. Prevent and treat non-communicable disease and mental health conditions. And number 9, build back better, and the 10, act in solidarity. Right? But we have 6 prominent global issue in 2021. The first actually is pandemic, officially COVID pandemic, environmental factor, economic disparities, and access to healthcare, especially in our country because we have many islands. Number 4, the political factor, and number 5, non-communicable disease, animal health, food securing, and the supply. So as practitioners, usually we always have questions. We all want to do the best for our patient, but we don't know what is the best. As a doctor, as a practitioner, as a neurosurgeon, sometimes we are in a doubt. What is our giving to the patient is the best or not? We don't know sometimes what is the best. Slide. Today, we want to talk briefly about the pandemic. You know that the COVID pandemic today is as a global burden. All of the countries in the world suffering from this pandemic. Today in Europe, the incidence of COVID-19 getting increased, but in Indonesia today already declined, but we must anticipate about the increasing or surge wave in Indonesia. Everyone is affected of the global pandemic. You know, almost 223 countries in the world affected from this pandemic, especially Indonesia. Today, we have number 2 for the increasing of the case of the pandemic. Now, this is our hospital. At the early of June, we have many patients came to our hospital, but even we have 68 beds for patients of COVID in emergency room, but it is not enough because per day usually came to our hospital more than 100 patients. So it looks like this, but today we can overcome this situation, and the patient came to our hospital about 10 until 20. So we can handle perfectly. What the cause of this? Because we have a new variant, we call Delta variant. It is very infectious, and patient came to our hospital with the severe and critical stages. We can see in the update of COVID-19 in the world and in Indonesia on ICAS 2021. We can see that the daily trend of COVID-19 cases globally is starting increase. Also in Indonesia getting decline, but it is very dangerous for us, to anticipate that Indonesia, it should be anticipated perfectly. Mobilization and isolation. If it is not tightened, it is very dangerous for Indonesia, because we know in several countries neighboring in our country getting increased, Indonesia getting decline, but anticipation is very important. How about in neurosurgical training? We know that the amount of the patient and cases during in pandemic getting declined. So we train our residents. We change the method of the training of our residents because we know that the cases is getting declined, menurun. This is in our department, neurosurgical epicenter COVID-19 pandemic, like in Sutomo Hospital. So we significant reduction in cases. So we have adaptation to the campus and hospital policy for neurosurgical resident and undergraduate students. The organization of resident for the service and digitalization of environment. COVID-19 and those of us to increase the using of digitalization in the in the training of neurosurgery training. This is our strategy for neurosurgery education. We have some procedure, how protect the residents and how the resident can increase the capabilities as a neurosurgeon, but protect him from COVID-19. I think everyone can read this slide. How about the problem of our country, especially in economic disparities and access to healthcare? We know that in Indonesia, we can see in the orange ones, Indonesia is, according to the World Bank, income group as lower middle income, with the amount of the neurosurgeon 377. Representation of the volume of essential neurological disease observed by existing neurological work given in our country. Distribution of Indonesia by region, we can see that more than half of neurosurgeons stay in Java Islands. More than 56% neurosurgeons in Indonesia stay in Java Islands. In Java, most of our neurosurgeons stay in Jakarta, number 2nd in Bandung, and then Surabaya and Medan. Another problem in the world, political factor, global medical issue, we can see shifting of the services. At the past, services depend on the social supporting, or it's called paternalistic. But today, shift to the partnership, and in the near future, shift to the commercial. It means business. It is very dangerous because business is business. Yeah, risk and benefit is consider the relationship between the patient and family and the hospital and doctors. Partnership maybe is the most suitable interaction between the patient, family, and hospital or a doctor, because the empathy, relationship, competency is very important thing. And work within the standard and patient-centered care is very, very important parameter. How the services to the patients. Yeah. Today, medical issue and economic issue is very challenging because the hospital or doctor relationship with the patient become to the commercial relationship. The most important thing in Indonesia, for especially program of government with universal coverage, it's called JKN, Jaminan Kesehatan Nasional, with the prospective payment. Sometimes the claim of the services is not matched with the the cost of the services. Sometimes the cost of services is less, not enough with the claim of the JKN program. That is very, very dangerous if it is not it is synchronized between the claim and the cost of care. What should we do about this situation? Economic issue or medical issue? Medical issue, it means accessibility, safety, and quality. Economic issue about the cost of care. So one thing should be remembered about the patient safety. Economic or medical issue, as a hospital or neurosurgeon, patient safety is number one to consider if we want to give services to our patient perfectly. How about the universal healthcare in Indonesia? Until now, about 82% coverage. And then comparing with the advanced health for all and tackling health inequities, this is our problems, and patient safety. How to maintain the patient safety? Theoretically, hospitals should have the hospital accreditation and clinical guideline based on evidence-based medicine. Clinical guideline is very important because it can guarantee the patient safety. Patient safety, it is very important thing to consider about the shifting of the services today. Talking about the clinical guideline, what is the clinical guideline? Clinical guideline is the systemic development statement to assist practitioner, neurosurgeon, and patient decision about the appropriate healthcare for specific clinical circumstances. Guideline are suggestion for care, not rule, but suggestion for care. The aim of clinical guideline is how improve patient outcome, best clinical quality. But we must remember that clinical guideline, it is a tool to assist in the art of decision making, do not constrain practitioner. Clinical guideline, it is not rule, but to assist practitioner, to assist us how to give the best clinical quality care. How about the clinical guideline that can to be guide us to give a value of care? Yeah. Value of care is very important thing. We know that value of care is the quality per cost, and quality it means outcome, safety, and services. Services it means satisfaction and access. Even we have very sophisticated services, it is not the people cannot access this. It is unmeaningful. So we want to have a very high value of care. What is the value of care? So we should construct, or we should guideline based on ABM, evidence-based medicine, and health technology assessment. This is the theory of the value of care, how to design the evidence-based medicine that very, very high value of care. Yeah. There's a clinical evidence analysis and then the technology assessments. About the outcome analysis, economic analysis is very important. So sometimes we forget about this. Yeah. Cost effectiveness analysis and ethical or legal analysis. This is very important. In the guideline, the most important thing is a recommendation. Recommendation based on value-based medicines. 3 factors influence the recommendation. The first one is clinical evidence. The second is patient view, and the third is health economic. 3 factors should be considered to make a clinical judgment, and clinical judgment is very important to make a recommendation. Making recommendation is the art, not the practice, precise science. It is not easy. Hospital should have a recommendation to do or not to do some procedure or some method of how to make diagnose the disease, especially in neurosurgery. This is the hierarchy of evidence. Yeah. Randomized control trial, cohort study, case report, non-systemic observation, experts' opinions. This is the highest clinical evidence as randomized highest control trial, maybe from a meta-analysis and grade of recommendation can divide 2 things: strength of recommendation and quality or level of evidence. Strength recommendation, it means strong or conditional. strong it should be done or not should be done. So conditional depend on the situation. And the quality level of evidence depend on the research result, high, moderate, low, and very low. I think in the next session, we can discuss deeply what is the grade of recommendation. So we should have guidelines in the neurosurgery making diagnostic or procedure based on value-based medicine, because guidelines are intended for the clinical and healthcare system to help them take better care of the patients. And then insurance and administrator may use guidelines to set policy on quality and payment for care. They're translating guideline recommendation into performance measures that are used to assess the delivery of care. So it's sometimes called pay for quality. The third lawyer, it is very important thing, may use well-accepted national guideline in the malpractice litigation. Today, not all of the neurosurgery procedure or neurosurgery diagnostic process already have clinical guideline, arguing that the physicians who have not followed such guideline without a good reason are negligent. So the third is very important. So in the next future, the near future, our association should have a clinical guideline based on value-based medicine, because we can protect from the legal aspect. The fourth guideline are suggestion for care, not rule. This is very important thing. So guideline are suggestion for care, not rule. There will always be individual patients who should be managed differently. Legitimate reason for this include biological differences in the drug metabolism, immune response, or genetic endorsement, the presence of comorbid condition, available resources determined by the social and economic environment or medical and the local level, and patient preferences. So the important thing from this statement is guideline are suggestion for care, not as a rule. So we continued about the non-communicable disease, heart disease, stroke, and cancer, diabetes, and other non-communicable disease account for 70% of all death worldwide, according to WHO. This is very important in neurosurgery field, stroke and cancer, brain tumor. Education play a role in the prevention on non-communicable disease, helping the population understand and change lifestyle factors, such as poor diet, inactivity, tobacco use, and alcohol consumption. But there is also correlation between income level and prevalence of non-communicable disease. Talking about non-communicable disease in neurosurgical field, we can see what is the most case in the neurosurgical field in Indonesia. We can see from this view that top 10 cases in neurosurgical services in Indonesia. We can see the traumatic subdural hemorrhage, epidural hemorrhage, benign neoplasm. This is the biggest source of the cases in Indonesia. Benign neoplasm, cerebral meanings, and then epidural hematome and subdural hemorrhage. Procedure according to the ICD 9, the craniotomy, it is a dominant in the procedure of neurosurgical in services in Indonesia. So neurosurgical care, neurosurgical care of all global neurosurgical care of global benefits. We can see that we proceed from cost effectiveness, neurosurgical innovation, from cost effectiveness, disaster response, many organizations, but lack of integration, expensive mode of neurosurgical care, and benefit of trauma and stroke integration, both innovation advance in nervous system diagnosis and treatment. how to curb the global issue in the world. So Indonesia Neurological Society want to rule the problem with the number one is explore opportunity to encourage neurosurgeons to practice in remote areas. We know that most of neurosurgeons in Indonesia stay in Jakarta, Surabaya, Medan, and Bandung. The second, introduce policy that reduce barrier and increase access to healthcare. Access to healthcare is very important. And the third, guideline in neurosurgery diagnostic and procedure based on the value-based medicine. So 3 program of Neurosurgical Society perhaps in Indonesia, it should be created in the next future. Thank you very much for this meeting, and I hope we can do better and better in the future. Thank you very much.
Thank you. Dr. Johnny already talked about how to take care, how to work, how to improve everything in this pandemic era. But since Dr. Johnny is very busiest neurosurgeon right now in Indonesia, so I just add a little bit about maybe the same problem for the trainee. Trainee, we do think to how to improve the education, and maybe all part of Indonesia, we are doing virtual lecture, virtual teaching and so on for the trainee. And the other one is how to keep the trainee health, how to protect from COVID in this area, quality and something like that. All of this, what we do during the pandemic, what Dr. Johnny suggests to do, already clear. Very good idea and very nice to know. And now, again, thank you for Johnny for the very excellent talk. We are learned a lot about this. And now we invite the second speaker. Everybody know the second speaker would be Professor Asmi Ilyas. Are you there?
Yeah, I'm here.
Okay, you talk about pediatric multidisciplinary surgery in pediatric epilepsy. How are you?
Very good,
You are very,
Alhamdulillah.
until yesterday. Now you will talk about this, and then everybody, I think, know in Asia, in Asian, Southeast Asian, Professor Asmi Ilyas. Now, your podium is yours.
Thank you very much,
Thank you.
Professor Sri Malyawan. Thank you again, Rohadi, for organizing this beautiful meeting. And today, I will talk about something different from what I usually involve. So this is one of another one of my concern and area of specialty which I really like, which is pediatric. And through this short presentation, I will share with you how we develop pediatric epilepsy program, mainly in our hospital, but it reflects the country in Malaysia. So this is actually my hospital in Kuala Lumpur, and this is, we call it Tunku Abdul Rahman Neuroscience Institute, where we do adult surgery nowadays, but most of my pediatric epilepsy surgery, we started doing it in this complex. Before we moved to a new hospital in early July 2018, which is about 2 years ago, where most of our activity and surgery is conducted in this hospital for all children less than 12 years old. And based on our data in Malaysia, published by our local neurologist, pediatric, Dr. Koo, in 2010, they see about 100 children with epilepsy every year in their epilepsy clinic among children. And almost 50% of them on one or more anti-epileptic medication, and about 30% are considered or classified as drug-resistant epilepsy. Probably this is the volume or the cases that we tackle, then we can offer surgery. So if you look at this video, this young and unfortunate boy actually was referred to our clinic with actually hypothalamic hamartoma, but as you can see, he come with a seizure. Yeah, she had a frequent fall, so she had multiple trauma to the head. So the parents, mother have to resign from working, so father has to concentrate, and they had to travel and to get the medication. So refractory epilepsy in children give an enormous challenges, not only to the healthcare provider like us, but mainly, especially for the patient, for the parents, family, and the community. And if happen in children, they can be progressive with potential risk to involve a structural damage to the brain and nervous system if it is left untreated. The drug-resistant epilepsy also can rapidly progress as the child develops, and they can have a development regression. They can have other associated morbidities related to psychological. Some of the patients who used to be a very great and very excellent student, and over a period of time, for example, like they have temporal lobe epilepsy, and their focus on study and the performance at school deteriorating. Yeah, so and some even in a small kids, they don't have a chance to learn, so they have learning disability. They're not able to talk, so it gives a social stigma and occupational consequences. So there are also reported risks of SUDEP, sudden death, following uncontrolled seizure. Therefore, in children, you need early referral and intervention. In adults, usually the definition, you need more than 2 years, but in children, because of their brain plasticity, and usually they have faster recovery, surgical intervention can be offered earlier compared to adults. So they are completely different group of patients. So there are diversity of etiology, and sometimes the diagnosis can be very difficult, especially those associated with age-dependent epilepsy syndrome. For example, spectrum of infantile epilepsy. Yeah, and their causes also sometimes related to metabolic and genetic, which are completely different from adults. And we started our first program in our hospital actually 2009, and it took very long. Initially, it was started by one of a late previous professor, I think Professor Ben, I think Prof. Zainal know him. So it started in University Kebangsaan Malaysia. At that time, UKM and our hospital are sitting together before they moved to a new hospital. So that's how it started. But it took very long time, almost 20 years before we can accelerate the activity for various reasons. Number one, not enough neurosurgeon. Number two, the development of niche area is not focused because we have 12 centers in all over the country, and we only have at that time maybe about 50 neurosurgeon in the entire country. So you have to do everything. So very difficult to subspecialize. So we only have our regular epilepsy pre-surgical conference started in our Pituitary Institute in 2012, and our first anterior temporal lobectomy ATL that we did was about 8 years ago in 2013. Then we start to form a bigger group, because we need a multidisciplinary team. So that was started in June 2013, and in April 2016, we invite our pathologists and so on, and the group is expanded, not only between neurologists and neurosurgeon, but the group expand. We have neuro pathologists, we have neuroradiologists, we have nuclear medicine specialty, and we have a neuropsychiatrist, neuropsychologist for older children, especially at the teenage and adolescent. So we train our technician to handle intraoperative neurophysiological monitoring. We involve genetics and rehabilitation. So if you can see here, this is a multidisciplinary team approach, which not only involve the surgeon play small role, but the entire team play a bigger role. So we also collaborate not only local, because to start we need a teacher. Even I learned from our colleague from Indonesia, like Professor Zainal. Listen to his lecture also is a learning. So we also have our local neurologist. This is Dr. Ahmad Ritaudin. So he spent 2 years in Children Epilepsy Program, Royal Melbourne, and his mentor is Professor Simon Harvey, and also the neurosurgeon there is Virginia Maxner. So we always in constant communication. When we have a difficult case, we consult them and they give us idea. And also we learn from senior Professor Ben Seladurai, who used to be in university, but he moved to private sector, and I went for attachment observation for almost 5 years whenever they have a complex case. So this is how we learn and we spend. So if you look at our data, so the first 5 years, the numbers are very small. And then you can see here, we divided our experience into 2 phases. The phase 1, we focus on first something that we thought is easy and good outcome, lesionectomy. And then we look at a selective area, temporal lobectomy with a good outcome. Then we assess our outcome in 2016, and we found that the results are comparable to international standard. Then we move to another level where we start to do palliative disconnective surgery and so on. And even we embark on functional disconnection, vagal nerve stimulation. So while preparing that phase 2, so we have ongoing training, case selection, we audit every cases, we cross-check by this multiple team. So this is a first phase between 2013 to 2017. We focus on lesional epilepsy, temporal epilepsy, and so on. And then followed by the second phase when we start to do disconnective surgery. So when we have multidisciplinary team approach, you can coordinate your activity. You become a national reference center. So all cases with require surgery under pediatric, we refer to our center, and then we will discuss, we take consensus. In case we are not so sure, we consult to another expert so that we can focus, we can create a high volume center, and the surgeon, the neurologist can have a very good experience, and we audit the outcome. And when we found a problem, we do root cause analysis and to make sure that the same problem does not occur, or we have to do something to make it improve. And with this multidisciplinary team approach also, we can do detailed preoperative workout. We do a non-invasive first because we don't have budget for invasive like depth electrode and grid, which is a need to pay. So, but we use other immediate available preoperative workout, for example, like EEG, video EEG, we have PET scan, so we use such technology. We do our audit performance, and then that's the way that we can do the development and niche area on every specialty which involved, not only surgery, neurosurgery, but also other medical and support team. So this is among a basic thing that we use. All is easily available. Clinical examination, semiology, serial EEG, ictal video EEG, which can available in most of the major hospital if it is not in central. So we have a MRI epilepsy protocol. We have a trained neuroradiologist. We do PET scan. And this is one of the things that I like. They did a 3D MRI T2-weighted surface recognition. So you, by doing that reconstruction, you can find the vein, that you have brain mapping, that if you want to do disconnective surgery, you can plan your line of resection. Even in our case, our pediatric neurologist, we join us in the theater, we will show where to resect, and then if we agree, then we proceed. So they stay together in the theater just to understand how difficult the surgery can be, rather than wait for surgery. So we use a lot of positron emission tomography, PET scan, using this, we measure at the glucose uptake. And this is just to give a level of confidence to see, for example, this patient, we subject the patient to ATL, and we found that from the PET scan, it shows that hypometabolic area in the temporal region, so that we know that the ATL will work. But there is a limitation of PET scan. It cannot completely delineate the margin of the lesion, but you may need to resect more. But it gives you some idea that the localization is tally. This also include your preclinical video EEG and so on. So you can use sometime image fusion between PET scan as well as the MRI. And this is important. We discuss preoperatively, multidisciplinary team between neurologists, neurosurgeon, and radiologists, so that we concern this is the target, and then we can confidently move in for the surgery. So this is just to show the example. And then I will show some example of cases that we do. So this is quite straightforward case where we start. You can see this is actually DNET, this embryoplastic neuroectodermal tumor. Very nice. I think every neurosurgeon can do most of it. So, but importantly, you need to understand when you do tumor surgery is completely different concept from epilepsy surgery. Yeah, because a certain tumor will secrete certain biochemical things that cause seizure. So like in this case, so you have to remove entirely the epileptogenic substrate. If you leave a little bit, then the patient still have seizure. So we need to scrap, to make sure that you know the margin. And if you leave even a small portion, patient will have seizure. But sometimes the tumor does not cause seizure, but the surrounding area become very active, and you need to resect the margin more than normal, and sometimes the brain looks normal, but you still have to resect. So that is epileptogenic zone. So you need to understand that in order for you to have a very successful result. So then we also do lesionectomy, tuberectomy. This is a case of tuberous sclerosis, patient with multiple hypopigmented lesion on the skin. He has cardiac rhabdomyoma, left eye astrocytic hamartoma, and so on. Seizure since 9 months. So you can see ictal shows on the right side, and the semiology also shows facial contraction, and so on. So we proceed with the, we use intraoperative ultrasound, and then you can see the target. We use surface marking just to have rough idea what is going to be. And you know that tuberous sclerosis, they can have multiple tubers. So instead of making a small incision for the first case, we make a big incision in case we found other area to operate in future, because the tubers can happen anytime. They can develop systemic tubers in kidney as well as in the lung and any other part of the brain. So we find the margin and you do a tuberectomy. So this is just an example of tuberectomy. And we use other adjunct to localize. We have a navigation. This is for adult, and we use brain lab optical, and we also have electromagnetic navigation by Medtronic, and sometimes we add on intraoperative ultrasound, especially for deep-seated lesion. This is good in terms of to improve the outcome. This is just to show video EEG, and the child developed seizure, and he has a temporal lobe tumor. So, and when we do ATL, so we have a certain strategy, and if it is on the left side, usually we resect about 4 centimeters from the tip of the temporal lobe. But if it is on the right side, we take a little bit wider, about 4.5 centimeters. We do neocortical resection first and followed by mesial resection. So what we do usually, we measure the tip using a pen, and we tag with what they call it, bone wax. I will show you later. And I will resect the superior temporal gyrus, the first 2 centimeters, and later I skewed the last centimeter, so to preserve the auditory memory area, and then I go perpendicular down there to the temporal base. Then we resect, we go towards Sibian area, and then as you can see here, so and into the ventricle, in order to expose the area. So we remove the neocortex, okay, and then the second phase is to find the hippocampus. So we use a navigation in the first 1 or 2 cases just to get an idea, so that you know, accuracy, and then also we want to use that for our training to familiar with that. So we mark our Sibian fissure, we mark the temporal tip superficially, the posterior margin of resection, inferior margin of resection. We draw a little bit about the hippocampus, so we have rough idea at the beginning. So initial surgery, the flap is a little bit big and broad, as you can see here, but later we move it into smaller one. So then we measure using this pop pen and we tag with bone wax, and then we slant it downward to measure the tip of the temporal lobe, as you can see here. So then we cauterize a little bit, and then we preserve, and then we go towards the anterior temporal tip. So and then we go perpendicular down and get into the temporal horn, and then we remove the neocortex. So the second phase, the mesial component, this is very important. So first, to identify the hippocampus. So it's quite easy to find it. The head usually void of choroid plexus, and the 2/3 of it, starting from the body and tail, you have a choroid plexus, and you have choroidal fissure, which is very easy to identify. Yeah. So and then we draw an imaginary line between the choroidal fissure and the M2, M3 junction. This is, we use sub-pial. We maintain the dissection when you remove the neocortex to protect the MCA. And then we resect anything lateral to it. Once you do that, you will take the uncus, you will take the parahippocampus gyrus together, and you elevate the fimbriae in order to get that. So then we measure the tip of the tail, from the body under the tail. Usually we take about 3 centimeters. We do not chase till the tail, because we have one case when we chase the tail, it's associated with a PCA infarction. Probably we use a cauterization to remove that disconnection, so that end up with PCA infarction. So from that cases, we were really careful on that area. We do not use bipolar unnecessarily. Yeah, so this is just to show the mesial component, and then we take 2 component, temporal and mesial. This is post-op scan. This is another example of temporal lobe epilepsy, but you can see entire temporal lobe is almost tumor. So again, you can see a tumor surface up. Yeah. So this one also we use ATL, similar technique. We resect the temporal lobe, but this one we take a little bit backward, because the tumor involves the superficial part more than the resected margin that we plan, which is initially 4 cm, but we take longer. So you can see here, tumor removed, and then followed by the mesial component. So we analyze our first 29 cases. There's not much difference between male and female. Predominantly are right-handed, and most patients do not have any risk factor, and 5 have febrile seizure. So we do not use any invasive monitoring to identify it. Okay, and then all have MRI abnormality, and then all majority have EEG, 7 have PET scan, and then 1 MRI only. And we have 2 big group, hippocampus sclerosis and tumor. Yeah, so the numbers of epileptic medication you can see before surgery. Some require 5 drugs, majority require 3 and 2, but after surgery you can see quite a reduction in terms of multiple medication following temporal lobectomy. And you can see preoperative finding, there are various lesions, and then majority are left ATL followed by right ATL. We also do temporal lesionectomy and so on. Okay, and then the causes in terms of pathology, 44% hippocampus sclerosis, and in our first group, about 55% consists of tumor. Yeah, ganglioglioma, PSA. Some of these tumors kept by the neurologist over many years. They're not keen to refer because they're not sure that we can do epilepsy surgery until they're really confident with our outcome. So means predominantly we have half hippocampus sclerosis and some temporal lobe tumor, even kept by pediatrician because they see the patient as a seizure. So in terms of hippocampus sclerosis, we divide it into all 3 subtypes, and majority are type 1. Okay, and then the outcome in terms of angle group, immediate seizure free. Angle 1, 96%. Yeah, continuous seizure, 3.4%. That is immediate post-op. And at 3 months, it dropped a little bit from 96% to 82%. And then after 1 year, it maintained about 82%. So this result is considered good because we achieve almost 96% of seizure-free, angle 1. Yeah, so this is comparable to international standard. So then this is just summary of the same finding, but we have some complication. About 4 cases have a complication. So this is one of the patients that have a big tumor, pilomyxoid, and then you can see a lot of perforated tumor encasing at the MCA area. We try to preserve, but I think we hit one of the perforators, and the patient developed lacuna infarct actually, but then she have hemiparesis, as you can see here, but we sent for intense physiotherapy. He recovered well, but still have a slight weakness. So this is second case, at 5 months old, and then subsequently, since 9 months, he continue have a seizure non-stop until the age of 7 years old. And then if you look at the MRI showing that complex right cerebral malformation, and then PET scan also showing that reduced uptake on the posterior component. So it shows that the target area is at the back. So we decided to do front TPO, temporal parietal occipital disconnection. So patient had previous shunt. We have to design the incision slightly different to cover the previous shunt. And then we use a navigation. We inject some reconstruction view so that we have some idea about what we are going to face. And then you can see from the surface. So this is a line of resection that we plan for the TPO. Usually we take the motor strip and one gyrus behind, and we do the disconnection. We start with ATL, standard approach, then we get into the atrium, and subsequently we complete the disconnection, as you can see here. Yeah, and then this is again post-op 3D situated surface. You can see a complete resection, disconnection. Patient unfortunately developed intraventricular hemorrhage post-op. We went in to remove it, put EVD, remove the shunt, and we challenged the shunt. He do not need shunt, so lucky. Yeah? So he shunt free and seizure free, and then she can play and attend normal school. Yeah? And then he had I think reduction of medication. So the parent and patient very happy, despite 2 surgery. So another case, 1-year-old boy, seizures in day 1 of life, essentially never seizure free. Spent most of 1 and 8 months of life in the hospital due to seizure. She had required intubation and sometimes BiPAP because of uncontrolled and desaturation during seizure. And all seizure and Iter EEG were localized to the right hemisphere, and the diagnosis was right hemimac. And you can see on the MRI again, just to show the anomaly on the right hemisphere. Yeah, and then 3D again, surface reconstruction. So give rough idea, because I look at the vein. The vein is a very good surface marking. Yeah, and then we go to the gyri. So before all, we discuss. Yeah, we look at the monitor. We discuss between neurologist, neurosurgeon, and neuroradiologist, and then we decide the line of resection before surgery. So when we open, we already know where to find the target. Again, of course, EEG and VTR is so important. So we use EM technology to target, and there are steps for the ATL. So we use a peri-insular hemispherotomy to disconnect and to make sure that the patient had seizure free. I think this is the technique that we use. Importantly, frontobasal disconnection. And we have the first 2 cases, we have a recurrent, and we did post-op MRI. We found that the frontobasal was incomplete, and the disconnection at the insular area was incomplete. So we decided to change our technique. We go aggressively more towards frontobasal, and also instead of do through the insula, we elevate using this technique and disconnect the thalamus basal ganglia from the cortex. This is post-op, and then a patient actually still having lead making. Okay, and then you can see he was fit free, and then he got hemiparesis a little bit. Yeah, but with the physio, it's improved, and then we send the patient home on day 29. So this is again 3D recon. So another case that we do a vagus nerve stimulation. This is again a neuromodulation. Herpes encephalitis, 6 months, multiple seizure, frequent fall, multiple medication, EEG, bilateral discharge. You cannot localize it. Yeah. So MRI also abnormality on the right and could be on the left. So resection maybe not be able to control the seizure. Yeah? You can see hypermetabolic area in both sides of the brain. So we did almost, I think in children, about 20 VNS implantation. So in the past 3 years, so about 106 model in 18 patients and 2 using 103 model. So the youngest we inserted 2.8 years old with average duration of surgery about 2.5 hours, and then majority are between 11 to 16 years old. This is model 103, and then this is expired. Okay, so we have some complication, mainly of erythematous and bone breakdown, superficial. And then if you look at the outcome, so the majority have improved, about 50% reduction following VNS. So this is just a very quick technique of VNS. You have to skeletonize the vagus nerve, 3 components, and then this is the most important part, to create pocket and subsequently to loop it, the 3 loop on the vagus nerve, and then just to show a different view, and then subsequently you fix it on generator, you stimulate it and check, make sure that the heart rate, this is expired, we can detect heart rate. When patient have tachycardia, they will automatically discharge. So this is the most advanced VNS that available in the market. So in summary, we found that based on our little experience, surgical resection has been proven to be effective, especially in MRI-defined lesion. Short-term seizure outcome is comparable, that based on our series, to those reported in epilepsy other center that already established. Decision and choice of surgical intervention in pediatric drug-resistant epilepsy requires consensus from multiple discipline team, and patient and family have the right to know, well informed in advance, how much expected seizure reduction. For example, like VNS, you cannot get 100% seizure reduction, at least 50% seizure reduction, because the cost is very high. So with that, I end my presentation. Thank you very much.
Thank you, Professor Asmi Ilyas. Very wonderful lecture. I enjoy it. I learned a lot about it. You talk about the first one is patient selection, and the second one imaging for this. And then the most important thing is multidisciplinary teamwork. That is the most. And then you also describe about surgical technique and outcome, and then complication. Again, thank you. Very wonderful lecture. Now, can we move to another lecture? Okay, since there is a plenary, there is no question, no discussion for this. Okay, so we move to next speaker. I cordially invite the next speaker would be Professor Yoshihisa Kida from Japan. Are you there, Professor Kida?
Oh, yes, yes, I'm here.
Okay. Yeah, okay. You will talk about radiosurgery. And is there any CP, the committee? You have the CP for Professor Yoshida?
Yes.
Professor Yoshida Kida?
Yes.
Graduated at Faculty of Medicine of Nagoya University in 1971. I got scholarship there in 1991, under supervised by Professor Sugita at that time. So
Sugita.
Now, yeah, you have a lot of, this is CP very much. Now is main interest, treatment of brain tumor, especially interested in the radiosurgery of benign brain tumor, like intracranial schwannoma. Secondly, radiosurgery of vascular malformation, and so on. And the third is treated many functional brain diseases. Very interesting. And now the podium is yours. Please, Professor Yoshida Kida.
Thank you very much. A kind introduction for me. Professor Sri Mariam, thank you very much.
Yes.
This is such my lecture.
Yes, you can share your slide.
Yes. Do you hear me?
Not yet. Not so clear. What about? I don't see yet your slide.
You don't see?
No, don't see it yet. Not yet.
Not yet.
I'm sorry, not yet.
Okay.
Okay.
I try again.
Sudah, Pak.
Sudah?
Yes. How can I do to show?
Please, the committee help.
Could you please open my PowerPoint, which I've sent to you?
Yes, we will try to present your presentation right now.
Yes, please.
Okay, now it's very clear. Your slide will be there.
Sorry to disturb you.
It doesn't matter. The voice is not so clear. But your voice is very clear. The slide.
Here's the annual rate of hemorrhage from brainstem cavernous malformation
for you
after
giving
surgery.
me a chance to talk at Second Asian Congress of Neurological Surgeons. Today, I would like to talk on the issue of radiosurgery for symptomatic cavernous malformation, especially for brainstem lesions.
Can I start the first one?
Yes, you can start it. Very good.
I would like to introduce myself. I just started my career on radiosurgery on May 1991 at Tokamak City Hospital in Japan, and now in charge of Gamma Knife Center in Okuma Hospital, Nagoya, Japan. My main interests are vascular anomaly like AVM, AVF, and cavernous malformation, and the benign brain tumors. I have no conflict of interest for this study. Karim et al. Demonstrated the natural history of cavernous malformation, indicating a bleeding rate of 0.25% per person per year.
Can you see
and a
my
seizure
slide?
rate of 1.51% per person per year. In another study, Robinson et al. Reported a bleeding rate of 0.7% per year per person per year. However, once they are symptomatic, the natural history is totally different. In 1995, Kondiolka et al. Reported that the hemorrhage rate was 0.6% per year per case without prior hemorrhage, and 4.5% after a single hemorrhage, and surprisingly, 32% after 2 or more hemorrhages. I would like to tell you the first important point of cavernous malformation. Among the cases of cavernous malformation, annual hemorrhage rate jumps up after the first incident. We have collected 49 cases of conservative treatment, 29 cases of surgery, and 298 cases of radiosurgery. All of them are symptomatic cases and almost equal in the onset patterns and the location. But the lesion size is much larger in surgery group. To understand the real state after radiosurgery, it is necessary to understand a natural history of symptomatic cavernous malformation. Here are hemorrhagic-free survival of the symptomatic lesion with no bleeding, single bleeding, and 2 or more bleedings. Here is a comparison of annual hemorrhage rate between conservative and gamma knife group. In conservative group, there are 2 high peaks of annual hemorrhage rate within a year, as well as 3 to 5 years after the onset. Instead, the hemorrhage rate decreased and less than 5% after 2 years for gamma knife group. Three groups demonstrated a similar distribution in age, onset pattern, and locations. Only the lesion size is different. This slide summarizes the hemorrhage-free survival of 3 groups. Surgery and radiosurgery groups are better significantly in terms of hemorrhage-free survival. Here is the annual hemorrhage rate before and after radiosurgery. Hemorrhage occurred very frequent just before gamma knife treatment. After the gamma knife, hemorrhage rate score 8.4% per year per case within 2 years, 3.0% thereafter. Overall hemorrhage rates are 4.8%. I would like to proceed to the symptomatic brainstem lesions. We have 139 cases of brainstem cavernous malformations. Of course, all of them are symptomatic. Hemorrhage occurred once in 60, twice or more in 77 cases. Location of the lesions are in pons 94, midbrain 28, medulla 12, and others in 5. Interval of the first hemorrhage to gamma knife treatment was 30.6 months on average. Here is a treatment summary of brainstem cavernous malformations. Lesions with mean diameter of 12.8 mm were treated with a mean marginal dose of 12.8 gray. Follow-up period was 68 months in average. This slide shows the summary of the treatment. Almost half of the lesions shrunk, and the other half showed no change of lesion size. Before radiosurgery, hemorrhage occurred 30.8% per case per year. In contrast, after the treatment, annual hemorrhage rate dropped down to 5.2%. As adverse effect, subsequent bleeding were most popular, followed by brainstem edema in 3. Brand new lesions were found in 2 cases. Meanwhile, 6 cases were dead because of various reasons. This is a cavernous malformation in left middle or cerebral peduncle. This case showed a bleeding 5 times within 2 months. This is a cerebral cavernous malformation, which bled 5 times, showed a nice response to the radiosurgery without any subsequent bleeding. He experienced no bleeding after the first radiosurgery until the death by unrelated cause more than 20 years later. Here is a hemorrhage-free survival of symptomatic cavernous malformation after gamma knife treatment for each locations. Shallow locations in lobar and cerebellum are rather favorable. Instead, deep regions in basal ganglia and brainstems are worse in terms of hemorrhage. I would like to mention on the most difficult cases in brainstem. Those are very large, multiple, and hereditary ones. This particular case, 26 years gentleman, presenting with suddenly occurred headache and left hemidysesthesia. At the onset, a large pontine hemorrhage was seen. The second hemorrhage 2 weeks later, and third one after 2 more weeks. For large cavernous malformation in pons, radiosurgery was performed with 12 gray at the margin. Only the core of malformation was treated as encircled by yellow line. These are follow-up MRIs of this patient. Marked shrinkage of the lesion is notable 6 and 9 months later. I would like to show the most difficult cases, familial and hereditary ones. This particular case is 40 years female, suffering from brainstem hemorrhage 3 times with 12 years interval. At age 40, she was suffering from mental deterioration and left hem paralysis. She has undergone radiosurgery separately for 3 sites of brainstem with 12 gray at the margin respectively. She has an apparent hereditary background, and many of her relatives are suffering from hemorrhages in the brain. She has undergone radiosurgery separately for 3 sites of brainstem with 12 gray at the margins. Yellow line indicates the marginal margin of the lesion. This slide shows MRI 12 months later. No further bleeding occurred, and she has had very stable condition. This particular case was presented with left frontal hemorrhage first, This region was totally resected by surgery. He has had focal seizures often, which was difficult to control. Meanwhile, another bleeding occurred from another region and had seizures often. Finally, he was dead by status epilepticus 20 years later. Here are conclusions. First, only symptomatic regions are indicated for radiosurgery. Second, the basic understanding and knowledge are required for the treatment of cavernous malformation. Third, cases with repetitive hemorrhages in the brainstem are most suitable for radiosurgery. As a last, familial and hereditary cases are very difficult to manage. Thank you for attention.
Thank you, Professor Kido, for the very excellent and inspirative and information lecture. Thank you. Again, you talk about gamma knife. Gamma knife is what my idea is maybe APM or malformation on brainstem may become the first choice for this gamma knife, except it's not indication for this. Again, thank you. Unfortunately, Professor Kida, this plenary, so there's a lot of questions, but unfortunately, this we cannot ask this some question for you in this plenary. So again, thank you for a very wonderful lecture. Should we move to next speaker right now? We move to next speaker. Thank you again. I cordially invite the next speaker would be Professor Kazuhito Takeuchi from Japan. Professor Takeuchi, are you there? Hello? According to the schedule, now is Professor Takeuchi.
Professor Takeuchi currently cannot join us, but we already have his recording.
Oh yeah, okay, that's very good. Thank you for the committee. We start the video presentation of Professor Takeuchi. Thank you again, Professor Kida.
Yes.
We come to the next speaker. Very wonderful and very informative lectures. Very good. I have been in Komaki City also in 1991 just to see the gamma knife.
Oh yeah.
Yeah.
Thank you.
Yeah. Now you can stop the sharing slide. We start to the next.
Craniopharyngioma is still challenging. Various kinds of treatment has been reported. Due to its deep location, there is a risk of postoperative complications. Attempts of gross total removal result in significant morbidity in terms of hypothalamic dysfunction. Therefore, recently the subtotal removal with radiation therapy becomes a treatment choice. This is a report of radiosurgery for craniopharyngioma. In this report, radiosurgery gives very good local control in the short term. But in terms of long-term result, follow-up period was not enough in all reports, and in Professor Kobayashi's report, 5-year and 10-year local control was down to 50%. The craniopharyngioma is kind of chronic disease, especially for pediatric patients, so we have to think about the extremely long-term result. 10 years follow-up is not always enough for the patient. Of course, subtotal removal with radiotherapy is a treatment choice for the tumor severely adhered to the hypothalamus. Surgeons should always pursue a total resection method without complication. Nowadays, transfemoral surgery becomes the first-line treatment for cellular and paracellular lesions. We can achieve gross total removal without pituitary dysfunction by usual surgery. In this kind of giant pituitary adenoma can be removed with extracapsular dissection technique. In extracapsular dissection, it requires a precise dissection technique. This is also useful for craniopharyngioma removal. Transposition approach provides a direct access to the suprasellar area and even lower part of the third ventricle without any retraction of the brain, nerve, and vessels. Main locus of the tumor is always around the stalk, here. So, transposition surgery is a best choice for this kind of tumor. Firstly, I want to show you the skull base opening and reconstruction. We have to remove the septum inside the sphenoid sinus completely. After the removal of the septum, we can see the cella and the plum cella like that. At this moment, we have to remove the medial OCR here. That is because ICA is running like this, and optic nerve is running like this. And SHA, superior hypophyseal artery, comes from the ICA and supplies the blood flow to the optic nerve and pituitary stalk like this. Anyway, this artery arises from the ICA here. In the craniopharyngioma surgery, this artery is very important. Therefore, we have to expose this artery completely from the rising point of the from ICA here. Finally, we can get a very good bone window, like chef's hat shape. I want to show you the dorsum cellar approach. Look at this case. In this case, craniopharyngioma located in the third ventricle. The optic nerve is here, and the pituitary gland is here. Even if we ruled out the planum spinalis, surgical window is limited by the optic nerve and the pituitary gland. Only this corridor can be available. In such case, we perform the dorsum cellar approach. In dorsum cellar approach, we can compress the pituitary gland downward like that, and surgical corridor become large. In addition, we can get access into the third ventricle from more inferior side, like this. If we perform the transposition of the pituitary gland, we can have very big surgical corridor. The use of dorsum cellar approach is limited, but it is useful for some specific cases. We use linear or inverted T-shaped dural incision. But in this type of dural incision, the surgical corridor is limited. So we use dural tenting. Dural tenting gives a good visualization, like this. I guess you think the dural suturing is difficult. Actually, it's not so easy, but it's not so difficult. You can't suture the dura like under the naked eyes. You can't twist the needle in the deep surgical field. So we have to perform the specific surgical tricks. Hold the needle like a hook and just pull. It's not so difficult movement. Look at this. Hold the needle like a hook and just pull. And then we can suture it. Hold the needle like a hook and just pull. It's not so difficult movement, so please try it. Post-operative CSF leak is the most important concern of the extended transfemoral surgery. Of course, CSF leakage can lead to serious complications. Therefore, adequate skull-base reconstruction is of utmost importance. This is our reconstruction strategy. In the extended transfemoral surgery, in craniopharyngioma cases, the dural defect is always very small. So we perform this closure technique, shoelace dural closure. I want to show you a surgical video. This is post removal of the craniopharyngioma. We can see the pituitary gland and the optic nerve here. We thread the dura with fat graft. We suture the dura continuously like a shoelace, like this, and thread both sides of the dura with a double-armed needle. I usually use a 6-0 prolene, like this, and then put another fat graft inside the cella and suture it tightly tied. After that, another stitch was performed and compress this fat graft to the dural side. Like this, and tightly tied. That's all. We don't use nasal septal flap, and but the patient allowed to walk freely after post-operative day 2. Our reconstruction technique is in the JNS, so if you are interested in, please read this. This suturing technique is also useful for hematostasis. In craniopharyngioma case, we can encounter the hemorrhage from anterior intercavernous sinus, here and here. Of course, we can stop the bleeding with surgical, but the surgical corridor is limited by surgical. In such case, we use the suturing of the intercavernous sinus. Usually, 2 or 3 stitches is enough to stop bleeding. Like this. Hold the needle like a hook and just pull. Then we can stop the bleeding like that without reducing the surgical corridor. It's very useful technique. The next topic is vascular anatomy in suprasellar area. Superior hypophyseal artery is the most important artery perforator in the craniopharyngioma surgery. The SHA is a highly individualized vessel. There is 1 to 6 SHA per side with an average 3.3. The most important SHA is called the anterior SHA. That is the most anterior SHA comes from the ICA. This artery has some branches. Optic branch supplies the blood flow to the optic nerve, and the infundibular branch supplies the blood flow to the pituitary stalk and craniopharyngioma as well. To prevent post-operative neurological and endocrinological dysfunction, we have to preserve these SHA and branches. Of course, the perforator from PCOM and P1 is also important. Anterior taram perforating artery arises from the PCOM. There are 2 to 14 taram perforating artery with an average of 7 arteries. Anterior taram perforating artery supplies the hypothalamus and the rostral portion of the thalamus. So, to prevent the hypothalamic injury, we have to preserve these perforators. Now, let's move to the clinical cases. This is a typical case. 58-year-old male appears with visual disturbance. The patient have a suprasellar craniopharyngioma here, like that. In this patient, we perform the usual extended transfemoral surgery. And in surgery, at first we preserve the mucosa inside the sphenoid sinus. Mucosa was dissected from the bone and keep it inside the sphenoid sinus, lower part of the sphenoid sinus here, like that. Then we drilled out the sella and planum sphenoidale. At this point, we remove the bone around the medial OCR. Like that. We perform the ICG fluorescence. Like that. We can see the ICA here, and fortunately there is no anterior intercavernous sinus in this patient. We performed the dural incision, but the surgical corridor was very small, so we performed the dural tenting. After that, we can get a very good surgical corridor. We insert the arachnoid, like that. After that, we cut the craniopharyngioma capsule and evacuate the fluid content to debug it. Now we can see the pituitary gland and pituitary stalk. This is SHA. This is infundibulum branch here. So we want to preserve the pituitary function, so we preserve this artery as much as possible. There is optic branches like that. This artery is very small, but we have to preserve it for visual acuity. If you damage this artery, the patient will have the blindness. Now we are dissecting the tumor from the optic nerve. This rotating movement is very effective for dissection. This is optic chiasm, and now we are dissecting the tumor from the lower part. This is a secondary SHA. This is important for the diabetes insipidus, but not important for the anterior pituitary function. Now you can see the pituitary stalk fiber is running like that. Tumor was located inside the pituitary stalk, so we cut the pituitary stalk fiber and dissect the tumor from the stalk fiber like that. This membrane is not the tumor. This is a stalk fiber, so we have to preserve it as much as possible. Now we're dissecting the tumor from the hypothalamus. This is a mammillary body here. After the dissection, we can remove the tumor with a suction tube. Gross total removal was achieved, and we can see the pituitary stalk, and this is ICG angiography. Very good blood flow to the optic nerve and pituitary stalk and pituitary gland as well. After that, we performed the shoelace dural closure like that, and covered with mucosa inside the sphenoid sinus, like this. Post-op MRI showed a gross total removal of the tumor, and patient visual acuity was improved immediately after surgery, and patient had a normal pituitary function. The next case is 11-year-old female happy with visual disturbance and palm hypopituitarism. In this patient, patient had a huge craniopharyngioma, and the tumors got buried into the third ventricle and frontal side. We performed the extended transforaminal surgery. The dura was incised, and at first we performed the internal decompression in around this area, and fortunately the tumor was soft, so we evacuate the tumor like that. After that, we performed the incision of the dura of the pronounced synodale. After that, we performed the dissection of the tumor inside the frontal side. We are very carefully dissected and cut adhesion. After that, this is the optic nerve. We will very carefully dissect not to injure the SH here, this artery, and we are dissecting the tumor from the hypothalamus. Maybe this is a chiasm. In this patient had a complete hemianopia, but we preserved the nerves here. Now we are dissecting the tumor from the third ventricular floor. Fortunately, there is a not so severe adhesion inside the third ventricle, so we could dissect the tumor from the hypothalamus like that, and finally we can cut and remove the tumor completely. Now we can see the foramen maroon here, and with the 70-degree end scope we can see the interhemispheric fissure here. This is post-op MRI. Gross total removal was achieved, and patient visual acuity was improved immediately after surgery, but the hemianopia remained. Patient had a panhypopituitarism equivalent to the preoperative pituitary function, and but normal cognitive function. So the patient is doing well. This is a third case. This patient had a huge craniopharyngioma expanded into the third ventricle and prepontine cistern like that. In this patient, we perform the Transposition approach like this. But in this patient, we incise the dura around here and here. We don't incise the dura around this area. For doing so, we can perform the skull-based reconstruction very easily. And at first, we access to the cyst from the lower side here. Then we can debulk the cyst with intracranial pressure, as the case 2. This is surgical video. We perform the usual extended transfemoral surgery. This is a posterior crinoid. Posterior crinoid was also removed. And this is dorsum sera. Dorsum sera was also removed, like that. Of course, severe bleeding will occur because of the blood, vagal plexus will exist around this area. So we incise the dura and debulk the cyst. After that, we incise the dura of this area. At first, we dissect the tumor from the optic nerve. The adhesion was relatively strong, but this rotating movement was very effective for dissection. This is a pituitary stalk, and there is a SHA infundibula branch here. We are very carefully dissected, and this is this is a optic chiasm here, and subacinium is here. There are many perforating arteries around this area. We are very carefully dissected it. Usually the adhesion to the vagal artery is not so strong, so perforator is very big concern, but in this patient, I'm very lucky we could dissect it completely. This is very lateral side, but adhesion was not so strong. We remove the posterior side like that. After that, we access to the cyst around this area from cranial side. This is vagal artery. But unfortunately, the cyst wall was very fragile, so we very carefully dissect and remove it. Finally, we could achieve the gross total removal. This is SADNAP. And this is ICG fluorescence. We can see the good flow, good blood flow to the of the perforators and the SHA as well, and the vagal artery. And perforators had a very good blood flow. We performed the shoelace dural closure at the cranial side and planum side as well, like this, and finish surgery. Post-operative MRI shows the gross total removal, and fortunately we could achieve the improvement of the cognitive function, and patient had a normal pituitary function, normal anterior pituitary function, but the patient had a mild, very mild DI after surgery. This is the last case, 80-year-old boy appear with headache and vomiting. MRI revealed the hydrocephalus with a huge third ventricular type craniopharyngioma. This patient had a conchoid type sphenoid sinus, so we have to drill out the conchoid bone completely, then remove the dorsum sella to access to the third ventricle. This is surgical video. This is sphenoid sinus. In the conchoid type bone, we have to remove the compact bone. After that, we can see the cancerous bone around that, like that. The cancerous bone can be removed very easily with curette or slow drilling, like that. Then you can see the compact bone again, like that. This is a crevice. Crevice was also exposed, like that. And finally, we can make a usual sphenoid sinus. After that, crevice was also removed, and in this patient, we performed the transposition of the pituitary gland, like that, and then we can get access to the third ventricle, like that. We cut the craniopharyngioma membrane, and now we can see the stalk fiber, like that. We dissect it, and craniopharyngioma was also dissected from the stalk fiber. Very carefully dissected. This membrane is not a tumor capsule. This is a stalk capsule, stalk fiber. So we have to preserve it. After that, we dissect the tumor from the tuberosinium, and now we are dissecting the tumor from the hypothalamus. The adhesion was relatively severe, but we could dissect it. Now, this is a mammillary body that was also dissected, and now I'm dissecting tumor from the anterior commissure. Finally, we can remove the tumor, like this. Tumor was gross totally removed, and the pituitary gland and the pituitary stalk was remained here. This is the third ventricle. Foramen Monroe can be seen, and the damage to the hypothalamus was minimal, like that. This is post-operative MRI. The tumor was gone, and all symptoms were resolved immediately after surgery. But the patient had a GHD. But this is a post-operative day 1 photo. Our patient was doing very well, like that. In conclusion, endoscopic transsphenoidal surgery becomes the first-line treatment for craniopharyngiomas. Transsphenoidal surgery is very effective in avoiding neurological complications. Thank you for your attention.
Thank you for a very good video presentation. Unfortunately, there is no discussion because the speaker was not present in this session. Now, can we? Okay, Professor Takeuchi, thank you for very good presentation and very informative. And we all can learn the lecture you are presented in this session. Now we can move to the last speaker in this session. Professor Vladimir Banes from Republic of Czech. Professor Banes, are you there? Hello? Hello?
It seems Prof. Banes is not joined us yet.
Okay. Okay. We wait. So the last speaker would be Professor Vladimir Banes. We'll talk about arteriovenous malformation, series of case and how I do it. Hello, Professor Banes. For the committee, is there any video presentation for Professor Banes, or is there any message from him? He will be present or not?
Prof. Banes plan to present live, Doc, but he is not yet joined us.
Okay, we wait.
I guess we can wait for 5 minutes, Prof.
Okay. Okay.
Okay, thank you.
For all participants, I'm sorry, maybe Professor Banes has disturbance in his connection. We wait. Good afternoon, Professor Banes. Are you there? I cannot hear from you.
I'm sorry, Professor Sri Mulyawan. We are from ACNS committee only to show the curriculum fit of Professor Banes. Maybe we can wait until 5 minutes, or it's depend on you. If there's any question from the participant, please welcome to open the discussion for effectivity of the time. Thank you.
Okay, thank you from the committee. Thank you. Let show me the CV of Professor Banes. Yes, the last speaker in this session will be Professor Banes, Junior, MD PhD, Institute of Clinical Neurodiscipline Chairman, Professor and Chair Emeritus, First Medical School, Charles University Postgraduate School of Medicine, Central Military Hospital, Neurosurgery Department. While waiting, maybe the participant want to ask some question to the speaker before. If you have question, you can directly or via chat. You can ask the speaker before. For the committee, the schedule must be 13:45. So it just put, now it's 43. So we wait until 10 minutes more. Is there Professor Takeuchi there? If there's one question from the audience.
Prof. Takeuchi is not present, Prof.
Oh yeah. Okay, unfortunately, Dr. Rama, we cannot, Takeuchi is not present.
For the question for another speaker, you can submit this question in the chat and we will send the question to the speaker through email after the session.
You can get the this.
Thank you, Professor Sri Maliawan. We're very sorry for the reschedule. And so this is the last plenary session for the day. We will move on to the first satellite session. There are 4 interesting discussions that you can participate in. If you would like to join one, you can click the link in the chat box, or you can join via our website. I hope you find the discussion useful.
Dear Prof. Sri Maliawan.
Yes, I am.
Prof. Vladimir is just joining us in the...
Oh, you join?
Yes.
Okay, we can start. We can continue.
Good
Thank
morning.
you.
Good morning, Prof. Vladimir.
Prof.
Good morning, Prof. Vladimir.
Morning. Finally, I hear you. I was afraid already.
Okay, we will start. I guess we will start your lecture.
I am Sri Malayawan, okay, who conduct this session. Good morning also. Maybe there's early in the morning there.
This.
Okay. You will talk arteriovenous malformation series and how I do it. I already introduced you just introduce you to the participant. Now the podium is yours. Yeah, please share your slide.
Thank you very much. Let me share the screen.
Yeah.
Do you see the screen?
Not yet. Yes, yes. Very clear. Okay.
Very good. Very good. I must excuse myself that I haven't been here. There were some problems with the connection at the beginning, but now everything's okay, I hope. So thanks for the invitation. It's a pleasure to be here. It's early in the morning in my country, but it doesn't matter. One should be fresh early in the morning, but this is usually not my case, but I shall try to do my best. I'm going to talk on AVM. There will be two parts of the lecture. The first part for young people, how I do it. Several points I shall point out. And the second part will be like our series and some meta-analysis, since it's important to be able to decide proper treatment for proper patients in AVM. So I hope to tell you something about that. What you now see here, it's 20 points I have written down on AVM, which are important from technical point of view, in my mind. I cannot document all of them on videos because we would be here too long. So only those red ones I have pointed out because those I consider to be important. What's important is to plan the approach. Once you decide to resect the AVM, then plan the approach and take your time in planning, in measuring the nidus, everything. Try to put the nidus on the surface and try to put it in a way, or a patient in a way that you would go along the long axis of the nidus and that your approach would be vertical. That means that you will be very ergonomic and you will be very comfortable during surgery. This is such an AVM in the left frontal lobe. From whichever direction on the left you would arrive, you would have to retract the frontal lobe, the left dominant frontal lobe. So the logical approach to keep it vertical, to keep it easy, not to harm anything, is coming from the opposite side through falx, and it looks then like that. See that here is the reflected falx on the side, and your approach is very straightforward, very clean, very not easy. No, not a single AVM is easy, but very easy, I shall say. Okay, let's go forward. This is the angio after the surgery. This is the same case in the occipital region. Again, the AVM will be attacked from the opposite side through falx. And you see that again, you will have your approach vertical, you will have your AVM in your direct vision. The next point, which I feel is very important, is large enough craniotomy will be on the nidus margins, that's logical, but then opening dura carefully. There are very frequently adhesions between nidus and dura, and the most frequently these adhesions are between dura and venous part of the AVM. The veins have some propensity to grow into the dura. Let me show what it looks like. Come on. Okay. You see the dura is open, but it's not yet reflected. And once you reflect it, does it pray? Yeah, it does now. And once you reflect the dura, you see many adhesions between the nidus and the dura. Should you tear one of the vessels, your AVM surgery would immediately turn into a bloody event with no orientation, with catching the bleeding points. So be sure to open it very carefully and very sharply. Take a look, it can start bleeding very easily. It's very fragile. As always, the vessels are not in a good condition. You see, suddenly you have the bleeding without any problem. One more case like that. Again, adhesions and adhesion between the vein and the dura. Again, cutting sharply. So that was point. Temporal lobe. The main draining vein is copying the Sylvian fissure. There are feeders from the middle cerebral artery. And once you start your dissection, you really go suprarachnoidally, cutting the arachnoid sharply, and you get very good orientation, and you get a very good feeling. Later on, it turns into a battle, but at the beginning, the AVM surgery must be very clean, very, very careful, and very precise, because thus you get the orientation. Take a look, for instance, on this artery over here. It looks like a feeder. Everyone would have the tendency to occlude it now. You are in a Sylvian fissure. Don't occlude any artery unless you know well that it goes into the AVM. And you see that we slowly are getting to the Sylvian fissure. We slowly are exposing the superior temporal gyrus. And let's go to the next point. In the same AVM, dissect all the en passage vessels. That's very important, because you just save the brain. Patient coagulation. Take your time to coagulate any vessel, and cut the coagulated vessel stepwise. Should you cut it at once, the ends would retract and the vessel may bleed. Should you cut it stepwise, just opening the lumen and it bleeds, then you easily can coagulate it. Take a look here. Here we go. Already in the same AVM, the superior temporal gyrus is exposed, and we will see that superior temporal gyrus is not part of the AVM. There is this little tiny artery which belongs to the superior temporal gyrus and has nothing to do with the AVM, so it's separated. Of course, nothing would happen. Should it be coagulated, but why? You don't need to do that. And now we shall find a little bridge between the draining vein within the ninus and the draining vein in the Sylvian fissure. And now just let me show you how long a time I take to coagulate this vessel. I really take my time. I coagulate it repeatedly from one end to the other, because these vessels do not have a proper vessel wall. They do not react well to coagulation, and they may be still patent despite your feeling that you coagulated everything. And then cut it stepwise. Let's go forward. Identify the bleeding point, and don't go forward unless you control the bleeding, since there is a propensity that these bleeding points might multiply, and suddenly you end up in a bleeding lake. So deal with one after the other. Take a look, it's bleeding over here from one of the draining points, from one of the draining vessels we've seen previously, and just deal with it in whatever way you deal. Don't just let it go and go forward with your dissection. Go forward with the dissection only once the bleeding is controlled. This was very good. And now you see the vessel underneath the AVM, and as you dissect further, suddenly you realize that this vessel, and that was the original one, which I've shown you the feeder, is not a feeder at all, but one of the main branches of the middle cerebral artery. And it has nothing to do whatsoever with the AVM. Okay, let's go forward. It is the postopangio. So unpassage arteries, and that's probably the main technical message from my side, must be treated as any artery must be treated as unpassage as until proven otherwise. Let me show you another AVM. You would easily guess that this is a feeder of the AVM, which is over there. But as the dissection progresses, suddenly there is something underneath over here. And this branch of the artery is only passing along the border, again going ahead. And you see this is the true feeder of the AVM. Not this vessel, but this vessel which is hidden and which you will find only later. So let me show you what it looks like at the end. At the end we have the cavity and this artery, which really looks like a feeder, has nothing to do with the AVM, it's only passing around. So unless proven otherwise, any artery is unpassage. Abandoning feeding arteries, of course, these are difficult, and now we are in the depths. You quit being the best neurosurgeon in the world, and you are fighting these tiny, tortuous arteries, which really like to bleed, which are nearly impossible to coagulate. So do not hesitate to use mini clips, or there are those small special AVM clips which are extremely helpful. So you may end up with several clips in the cavity. At the end of surgery, you may or may not remove it. It really depends. I usually do not remove them and leave them behind because these arteries bleed all the time. Do have the important structures under your control all the time. You see this AVM in the CP angle, and once you dissect it, you have the 5th nerve over here, you have the 7th, 8th nerve over here. Both these nerves are circumferenced by the arteries and the veins of the nidus, which is underneath the sucker. And as the resection progresses, you would like to see both nerves all the time, having them under control. So be sure to look for this. Along the vein, it's very rare approach and very seldom. You see the minor AVM, very small one in the colliculi area in the quadrigeminal plate, and our endovascular people refuse to embolize that because they thought this is only unpassage, the artery, this one. Gamma knife surgery or radio surgery for brainstem lesions, I don't really like it much, so we go for surgery. And you see that the only orientation which was possible was the atypical vein in the middle, coming down to the quadrigeminal plate. It is the ECG. But which is the feeding artery, which artery is unpassage, which artery is just going there, it was impossible to decide. And once we are in the mesencephalon, you do not want to sacrifice anything. So we just went along the draining vein, cutting away all the vessels entering the vein. It will be the ICG. This is at the end. The vein is being cut last, but all the feeders were already cut through. And let me show you the postopangio. That's it. The patient did well. Preserve the vein until the end. This sounds like logical and like lesson number 1 in AVM. But check this AVM. I didn't sacrifice it intentionally. I sacrificed it by mistake. You know, this is the phase of surgery where everything goes well, everything's just fine. No retractors at all, which I never used prior, but if you need a retractor, just put it in. I became lazy. I just wanted to make it a little easier. This was the only use of the retractor. It bleeds. To control the bleeding, it really is not that difficult because I knew where the bleeding is from. But look what happened. The brain started bulging out, bleeding from the remnants of the AVM. We finally managed. Let me show you images. Come on. Someone takes care for time, please. And you see that the extent of restriction was a little larger, but the patient fortunately did well. Let me show you combined treatment with embolization. This was a case like that. After 7 years and several embolizations, we get to this stage. We said, okay, let's do the surgery. I show you only the part of it, because all the vessels which were embolized, nearly all of them bled. I had to deal with, that's it. You see the bleeding, incessant bleeding, and coagulating the plastic vessels, which was nearly impossible. So this is really quite frequently very difficult surgery. You are moving the hard object, lots of onyx, it stinks, which wouldn't matter that much, but vessels which appear to be occluded are not occluded. This is at the end of surgeries, and you tend to follow the draining veins deep into the brain, and always the embolization takes a larger amount of brain in the vicinity, so it's not that precise that only the part of the AVM is embolized. I will explain later, and I will come back to this. In ICG, it's good that you see the direction of flow. Otherwise, I don't see any major advantage in all these beautiful images, only the direction of flow. The remaining AVM wouldn't be shown. This is again ICG, but we don't need to see that. The timing. The timing is very, very important. It's always elective in a cold phase unless there's a bleeding and unless the nidus is accessible. You do not get the orientation in the body brain. So whenever possible, leave it behind and resect the AVM only in a cold stage. Not in this case, he resected the AVM all. This is after. So once again, 20 points. Let's jump across these unhappy cases. Or Mr. Chairman, do we have time to see the cases and then the series?
Yeah, you still have 6 minutes.
6 minutes, so I shall go to clinical part. It's more important, not the cases. Let's go to the part 2. These were 2 unhappy cases just to show that it's not really that. So this is our series of some 300 patients. It's not, it's 2 years ago we did it last time. And you see that we have used all the modality of treatment, and the patients were assigned to the group according to the modality, which really was like the one we used mostly. So patient who was embolized and then AVM resected surgically is in a surgical group. The patient who was embolized and then went for gamma knife is in a radiosurgical group. The important points are always effectivity, the total resection, that's the only goal, and of course surgical morbidity mortality. So in our surgical group of 150 patients, we have at 97% effectivity. There were only few AVMs which we didn't resect radically, with the surgical morbidity mortality 3.4%. In endovascular group, which was small, only 59 patients, we have had 5 major complications, which meant 8.5 morbidity mortality, and effectivity, it means radical exclusion or total exclusion of the AVM was in 37%, which is high. Still, we left that behind. This is the comparison only of endovascular and surgical, and you see that in Spezia-Martin grade 1 and 2, we had 100% effectivity and 0% morbidity mortality. This is the fact to be kept for later. In a radiosurgical group, 2 patients out of 51 bled and died, and the efficacy was 58%, which is something we've seen in literature, of course. The observation is, of course, the legitimate approach. We have had 54 patients which we didn't do anything. Few of them were in a very bad condition, Glasgow coma below 8, major deficit. So these were the because of the initial bleeding, but the rest of the patients were patients who we think that any active treatment would be dangerous. We've seen one spontaneous thrombosis, which means effectivity of 2%, and over the period of 15 years, 3 patients bled and died, giving morbidity mortality of 5.5%. So altogether, out of these 300-something patients, we were able to treat and eradicate 73% of the AVMs with 4.1 procedural morbidity mortality and 11.1 morbidity mortality in total, which was given by the initial bleedings. And there is a surgical effectivity meta-analysis of the articles which appear. You see that the effectivity in surgical group always is something like 95, 96, 97%. You cannot leave part of the AVM behind. So there are exceptions. The complication, again, the meta-analysis is very coherent and very even. The result is some 7% morbidity mortality. What about the endovascular treatment? The effectivity is slightly above 20%, scattered, very much so, and a little change by onyx, especially in our hands. You see that we got with onyx only as high as 30% with effectivity, but the complication rate, again, very even from all the authors who published that, and it is the same 7% as in surgery. What about the radiosurgery? Effectivity very scattered, but still we easily get to some 60% effectivity. 60% of AVMs do react well to radiosurgical treatment and are eradicated. And the complication rate, which is not immediate, but some 6 months after the irradiation, again is 7% for this modality. This is the fractionated radiotherapy, very effective and very nice, but don't expect this result to be seen in all patients. It's not so. So what we used was the annular rupture rate as given by Aruba and as published by most respected...
Benes, 2 minutes more.
2 minutes more. I'm nearly done. I'm nearly done. And rupture rate, morbidity, mortality is 30%. It is not as malignant bleeding as from aneurysms, for instance. So on a horizontal axis, we have years. And patients are coming to us when they are 30-ish. So we counted for 40 years. And this is the probability of bad outcome is 2.2 yearly bleeding and 30% morbidity mortality. The blue line is the natural course. 40 years after the diagnosis of AVM, you have the risk of some 25%. The green line, the green is endovascular. And actually, with low effectivity and morbidity mortality of 7%, which is at the beginning, you do not change the natural course in a course of 40 years. So we do not use, this is one of the reasons, endovascular treatment as the solo treatment, only pre-surgical and only very, very seldom. The violet is radiosurgery, effectivity 60%, complication 7%. So you bring some effect to your patient 20 years after irradiation. 20 years after irradiation, you beat the natural course. And of course, this is the case of surgery where you are faster because you must resect the AVM. So you bring some effect to your patients 10 years after, provided you have 7% morbidity mortality. However, if you are smart, you will get lower morbidity mortality. You saw that in grade 1 and 2 we had 0. So you are effective much earlier. Going to Aruba, and this is really one of my, the one before last. The study virtually compared endo and radiosurgery versus observation over a very limited time. There were only 5 surgical cases, nothing else. So nothing could have been said about surgery. The only conclusion in my mind is that unruptured AVMs, Spezzer-Martin 1 and 2, should not be treated endovascularly or by radiosurgery. On the other hand, the only conclusion is that AVM treatment of Spezzer-Martin 1 and 2 is surgical, with no respect to presentation, no respect to location. All these are surgical cases because you have nearly 0 morbidity mortality. So in conclusion, good surgery is superior to radiosurgery, and it is superior to endovascular and natural course. Bad surgery, of course, inferior to anything. So what you need is competence, skills, experience, self-assessment, honesty. No AVM surgery is really easy. Honest information and patient choice. Explain everything to the patient and let him decide. To talk about high volume and well-equipped center is not easy because there are not many of them in the world. Use monotherapy. Don't be using 3 pre-surgical endovascular treatment and then surgery. Should you do so, you expose the patient to nearly 30% risk of serious morbidity and mortality. So this is combining, summing up. So use monotherapy if possible. What I have seen 4 times was failed radiosurgery followed by surgery. 4 cases, extremely easy. The easiest AVM surgery, and this was not studied sufficiently. There are not good cooperation between gamma knife people. I don't know why, but this is really obvious what should be done. Starting with AVM, 3 years later, there is still some remnant, take it surgically. Should you want to learn more, there is this book we have published some 2 years ago, and all these technical, epidemiological, and whatever facts about AVMs are there. Thank you very much for listening to me, and I hope I didn't take too much time.
Thank you, Dr. Benes. It's very interesting, very wonderful lecture. It must be a lot of questions, but because of the time and this plenary session, there's no discussion. But anyway, maybe a lot of questions maybe come because regarding compare between surgical and radiosurgery. Thank you again, very wonderful. And then this is take home message. We think about it. Let the patient choose what they want to be. And then now again, thank you, very informative and very inspired lecture. So the next, I let the committee, the master of ceremony, to continue this lecture. This session. Thank you. Thank you, Mr. Benes. The committee, the podium now is belong to the committee. Thank you.
Thank you again, Professor Sri Maliawan. So this is the last plenary session for the day. We're very sorry for the inconvenience. As I said before, there are 4 discussion rooms that you can join by clicking the link on the chat box or via our website. I hope you find this session informative.